epithelium. Next question is somewhat knowledge based. You have to remember that as GFR goes down, there is a decreased tubular reabsorption of both sodium and phosphate so as to maintain the equilibrium of the body. Calcium, potassium are handled. Calcium is mostly by the bone and potassium is mostly handled by the gut in CKD patient. But kidney tries to cope up with these two electrolytes even after the GFR decreases to many extent. And regarding SGLT2, the question was which statement about SGLT2 in the kidney is incorrect. SGLT2 inhibition enhances GFR in the short term. That's a wrong statement. It decreases GFR in the short term, and as we follow up the patient, it stabilizes the GFR in the long term. And first option was it reabsorbs more than 90% of the filtered glucose in an euglycemic individual, but if you block, it excludes only 50%. Because SGLT1 lower down the SGLT2, it take over the function when you block upper SGLT2. Here, all of the following are required to reabsorb water. You need hypertonic medulla, you need vasopressin, aquaporin 2 on the apical epithelium, and aquaporin 3 on the basolateral. Aquaporin 1 lies in the proximal convoluted tubule. It does not stay in the collecting duct. The blood and the iron loss per HT session in the modern era, blood loss per dialysis session is 1 ml and iron loss is 0.5 mg. If you see older references, the values were quite high, but in the current era of modern dialysis, newer dialyzers, we have substantially reduced this blood and the iron loss. The next question was which of the following is true? Here, acute aldosterone regulated potassium secretion is primarily via direct stimulation of potassium channels. It is not true. It is mostly by the distal tubular sodium flow. Mineralocorticoid receptors are exclusively expressed. It's not true. It is expressed throughout the nephron. Hyperkalemia-induced aldosterone secretion leads to high blood pressure. That is not true. It is due to hypokalemia-mediated DCP wing receptor activation. So the true statement here only is the sodium reabsorption increases the driving force for potassium and proton efflux in the distal nephron. Here, the kidney failure risk equation, we have only 4 parameters. Creatinine is not taken, rather eGFR is taken into consideration along with age, albuminuria, and sex of the patient. So, regarding gadolinium chelate agents, all are correct statement here. The risk of NSF is increased when the agent is administered to patients who have a liver transplant. This was the concern in the prior era. This is not true. The initial study ORA-LB by Brad Rubin and his group, they showed that they have a higher risk of toxicity, but the subsequent phase 2 and 3 trial have shown that voclosporin is associated with the lesser adverse events compared to the standard CNI, that is cyclosporin and tacrolimus. And the advantage of voclosporin is that we do not need therapeutic drug monitoring for voclosporin. So here our selection round ends. So our judges by this time will check your answers, and HOD sir will discuss, announce the final 5 teams with whom we'll continue with the final round. So anyone having any doubt or questions from the selection round?
I am মোটা হইতে যদি দিয়ে চাকরি চাকরিটা তো 1/45
We have a same score for 2 teams. So there will be few questions for 5th and the 6th team, and first 4 teams will be declared by HOD sir. And for 5th team, we'll have 2 or 3 tiebreaker questions, and we'll request those teams to come forward once the teammates are declared. Here same scope for 2 teams, so there will be few questions for 5th to the 6th team, and first 4 teams will be declared by HOD sir. And for 5th team, we have
The name of the winner teams will be declared after inauguration program.
Those teams will come forward once the teammates are declared.
After inauguration program.
Devapratim Ganguly and his team, please stand. Devapratim Ganguly. And second team is Pallav Sinha, MP. You have a time, we need a tiebreaker situation for these two teams. Your additional questions will be announced after the inaugural program.
আরে স্কোর সবাই সবই হ্যালো হ্যাঁ
All who are present in the auditorium, please sit in the front 3 rows. We have a very large auditorium. It looks relatively empty if you sit far and far and far away. All the students present here, please come forward and sit over here. Tanya,
Good morning. Good morning, respected teachers, my seniors, and my dear colleagues. Today, we have the pleasure of hosting the CME program organized by Department of Nephrology IPGMER under the aegis of Association of Physicians of India, West Bengal chapter, in collaboration with the Indian Society of Nephrology. Now, the major objectives of a CME program is to provide opportunities to update knowledge. We start the inaugural program, and for which I would like to welcome the President of Indian Society of Nephrology, Dr. A.K. Bhalla sir, who will be joining this program virtually. Secondly, now I have the honor of calling upon stage the President of Association of Physicians of India, West Bengal chapter, Dr. H.S. Pathak sir. Now, I have the honor of calling upon stage our chief guest, Dr. Debashish Bhattacharya sir, the Director of Medical Education of West Bengal. Thank you, sir. Now I have the privilege of calling upon stage our guest of honor, Dr. Ajay Chakrabarti sir, the DHS sir of West Bengal. Now I would like to call upon stage our guest of honor, our director sir, Dr. Malima Banerjee sir, to come upon the stage. Now I have the privilege of calling upon stage Dr. Debabrata Sen sir, our HOD. Now I request Dr. Sanjay Chatterjee sir, Head of Department of General Medicine of our institute, to come upon the stage. Now I request Dr. Arpita Rai Chaudhary madam to come upon the stage. Finally, I request Dr. Parthasarathi Karmakar sir, the Secretary of API West Bengal chapter, to come upon the stage. I request Dr. Now I have the pleasure of requesting Dr. Narayan Prasad sir, Secretary of Indian Society of Nephrology, who will be joining this session virtually. Thank you, sir. Now I request our PDT, Dr. Tanya Bhuya, to felicitate our esteemed guests by giving them bouquets. Dr. Tanya will now felicitate Dr. Ajay Chakraborty sir, our DHS sir. Now Dr. Tanya will be felicitating our director, Dr. Manimai Banerjee sir. Now I request Dr. Tanya to felicitate our HOD sir, Dr. Devabrata Sen sir. Now I request Dr. Tanya to felicitate Dr. Parthasarathi Karmakar sir, the Secretary of ABI West Bengal chapter. Now Dr. Tanya to felicitate Dr. Sanjay Chatterjee sir, the Head of Department of Medicine, IPGME. Now I would request our chief guest, Dr. Debashish Bhattacharya sir, and our guest of honors to kindly light the ceremonial lamp to mark the formal inauguration of this ceremony.
ইউটিউব চলছে বলুন, সত্য বলুন।
আমাদের ডিপার্টমেন্ট থেকে ছবি কে তুলছে?
Thank you, sir. Now, I would request our chief guest, Dr. Devashish Bhattacharya, sir, to say a few words for today's occasion.
Good morning. It's really very pleasure to be here in this early morning, and that too disturbing your schedule. But adjusting of time is very, very important. So quite naturally, all of us are here together to have this CME, and that is very important that both the departments, general medicine and nephrology, are hand in hand with each other for this CME program. I wish and pray to God that the whole day CME and the workshop that will be going on will enrich all of you, and we will be doing a better justice to our patients after being enriched through this CME. I wish a healthy life to all of you. Namaskar.
Thank you, sir. Thank you for your kind words. Now, I would like to request Dr. A.K. Bhalla, sir, the Honorary President of Indian Society of Nephrology, to give his welcome speech.
Thank you. At the outset, I will like to thank the organizers for inviting me to this inaugural function, being held jointly by Association of Physicians of India West Bengal chapter and Indian Society of Nephrology. So I bring warm greetings from Indian Society of Nephrology. The topic chosen, especially on World Kidney Day, which is celebrated on Thursday, second Thursday of March every year. And every year we have a particular theme. This year theme of World Kidney Day is kidney health for all and bridging the knowledge gap, spreading the awareness of kidney disease. And I think it is just appropriate that...
Sir, एक मिनट होल्ड कर लीजिए.
Yes.
इस लैपटॉप के साथ कनेक्ट कर देते हैं.
The topic chosen, especially on World Kidney Day, which is celebrated on second Thursday of March every year. And every year, hello, should we continue? Hello, Dr. Arpita? Hello? 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 Please, you can continue with my recorded message. Hello?
Dr. Arpita, you have to unmute yourself. नहीं, आपकी आवाज नहीं आ रही है, आपका ये म्यूट आ रहा है.
Narayan, the podium is connected. Can you hear me?
Yeah, you are audible now.
Yeah. Bhalla sir, please.
Yes. Now
there
it is audible.
Yeah. There was a technical glitch.
Okay,
Please continue with your speech once.
Okay, thank you. Warm greetings from Indian Society of Nephrology. I will like to congratulate Association of Physicians of India West Bengal chapter and the Vice President of Indian Society of Nephrology, Dr. Arpita Roy Chaudhary, for arranging this CME program on chronic kidney disease and organ donation and physician advocacy and quiz also, especially on World Kidney Day, because every year we have a separate theme for World Kidney Day. And this year theme had been kidney health for all, bridging the knowledge gap and making the awareness. So I think it is just appropriate that Association of Physicians and Nephrologists are joining hands together to spread the knowledge about kidney disease. Actually, to share the facts, we are only 2,000 nephrologists in the country. And the majority of the causes of CKD are diabetes and hypertension. And all these diseases are managed by physicians and GPs. So it is just appropriate that the care of the kidney care has to go beyond nephrologists. So I will request all the physicians to join hands in preventing the kidney disease and slowing down the progression of kidney disease. Let's control diabetes better, hypertension better, and make the public aware about various nephrotoxic things like desi medicine, Ayurvedic medicines, herbal medicines, and healthy lifestyle, so as to prevent the disease, because we are facing a huge burden of epidemics of diabetes and kidney disease in our country. So with this, I wish this update a grand success, and I'm sure in future also we will join hands together and we will launch national-wide screening program, especially for diabetes and hypertension. Thank you. About various nephrotoxic things like desi medicine, Ayurveda.
Thank you, sir. Thank you for your kind words. Now, I would request Dr. Narayan Prasad, sir, the Secretary of Indian Society of Nephrology, to give his welcome address.
So, with this, I wish this updated.
So, greetings from Indian Society of Nephrology. Professor Day, DG Health of West Bengal, President of API, West Bengal chapter, senior colleagues, ladies and gentlemen, it is always a pleasure to be associated with any advocacy program, particularly with our physician colleague. We have just celebrated, as you know from our President, Dr. Bhalla, we have just celebrated World Kidney Day on 10th of the March on the theme, the kidney health for all and bridging the gap, educational gap for better kidney care. And the theme was chosen whether we should have on the common platform all healthcare workers, all healthcare personnel, the people from the community and policy makers. Particularly today, DG Health of West Bengal is there in this seminar. So that is very important. Policy makers' role is very important. We should all sit together, decide how to curtail, how to reduce the burden of the chronic kidney disease. United Nations Sustainable Development Goal, we all understand, they have fixed a goal to reduce the all premature mortality by 30% by 2030. But that would not be achievable until unless we reduce the mortality because of the chronic kidney disease. Recently, a survey shown at present, death due to chronic kidney disease is the 12th leading cause of mortality across the globe. And it is likely that it would be the 5th leading cause by 2040. And at the same time, we have noticed that the death due to cardiovascular disease has been decreased by 30%, cancer by 15%, chronic lung disease by 41%. What about chronic kidney disease? Chronic kidney disease, death due to chronic kidney disease is increasing. So you cannot achieve the United Nations Sustainable Development Goal without reducing the burden of chronic kidney disease, without reducing the mortality because of the chronic kidney disease. We all understand the prevalence of the chronic kidney disease in the community is very high. 1 in 10 individuals are suffering from this chronic kidney disease, and the cost when all these chronic kidney disease patients go to end-stage renal disease, then the dialysis and renal transplantation kind of therapy remains the options, and none of the government across, even those who are doing pre-dialysis to all these patients requiring dialysis, they are facing difficulty in sustaining this program. When USA has a lot of problems, all other countries, this is very costly therapy. So what we aim to reduce this burden of the chronic kidney disease with our association, with particularly our physicians colleague, where most of these patients come first in contact. Patients with the diabetes, patients with the hypertension, patients with some of the autoimmune kidney diseases like IgA nephropathy, they come first in contact with the physicians colleagues. So we all needs to come on one platform, whether the people from the community, policymakers, and our physician colleagues would come all together and try to adopt a system where we can reduce the burden of the chronic kidney disease. Thank you, ladies and gentlemen. Thank you for this opportunity. Thank you, Dr. Arpita Rai Chaudhary, for this invitation. And Indian Society of Nephrology fully endorse this program. Thank you very much.
Thank you, sir. Thank you for your kind words of encouragement. Now, I would request our guest of honor, Dr. Ajay Chakrabarti, sir, the Director of Health Services, to say a few words for today's session.
Good morning to everyone. Today, we are just remembering how to improve the service of the nephrology. We know that there are huge number of cases that are undergoing dialysis in the peripheral health institutes, and they are not getting any support of any nephrologist. But only thing that they know that they will have to survive by doing dialysis twice or thrice in a week. And if there is any complication, they are simply either referred or ignored. But now we'll have to take up this challenge, because you see, you cannot get the nephrologist in everywhere. So we'll have to see that the medicine specialist, they cannot shut down their eyes just for the nephrological cases. We'll have to build up the capacity of the medicine specialist. Even the GDMO, they are doing the duty in the dialysis ward, that to diagnosis what is the problem, and they can take the basic support for the nephrological cases. Because the medicine specialist should be able to tackle the simple nephrological complications and simple remedies they should prescribe. because you see, maybe the best treatment is available in the Calcutta, but the patient are dying in the periphery. But we'll have, as a physician, we have taken the Hippocratic oath, so we'll have to stand beside the patient and do whatever we can do at our best. So today we'll have to see, we'll have to take the oath that the Nephrological Society, they have taken the charge. Dr. Orpita Rai is very much keen interested, and we all have to see that the capacity of the peripheral doctors to be improved so that we really give the effective treatment and care for the peripheral renal chronic kidney disease patient. And particularly for the dialysis, we will give the support and we will extend the support of dialysis. But at the same time, we are thinking of introducing the peripheral dialysis because many persons cannot come to the sophisticated higher institute every day, alternate day, to get the dialysis because the peripheral and the rural people, they need the dialysis. The pediatric patient, they need the dialysis, and peripheral dialysis is the best alternative for them. So whatever the costlier may be, but we'll have to take care to introduce the peripheral dialysis very soon. So now, again, I'm just appealing to you all that please stand with the patient and also let us upbring our knowledge and skill so that we can develop the courage to stand beside the nephrological patient in the periphery where they need it. Thank you.
Thank you, sir, for your kind words. We welcome upon stage Dr. H.S. Pathak, sir, the President of API Chapter of West Bengal. Now, I would request our guest of honor, our esteemed Director of this institution, Dr. Manima Banerjee, sir, to say a few words for today's program.
Good morning, everybody. Professor Debashish Bhattacharya, Honorable DME, DHS, and other dignitaries seated on the dais. My regards to them, the budding nephrologists, physicians, ladies and gentlemen. Now, this is a program being organized in association with Association of Physicians of India West Bengal Chapter and Indian Society of Nephrology and Department of Nephrology, IPGMA. So the idea, as others guests told, that physicians and nephrologists are interrelated, and so when they come on the same platform, the effect is definitely will be far-reaching. In continuation of the words which DHS sir just told, in peripheries and all, there are definitely dialysis centers are there, but nephrologists are lacking. So super specialty nephrologists are definitely very few compared to the demand of the subject or the specialist. So you can think about the way you two are coming together. You can think of the model which we have initiated in BIN telemedicine concept, that it is not possible, it won't be successful if we say nephrologists to go to periphery to provide dialysis service and guidance. Either they won't go, or it will be for a short-term successful project. In stroke and BIN, what we are doing is the neurologist which is on duty in ward is basically having a connection with the telemedicine setup, so that in periphery, whenever one physician or one medical officer is in need of some advice of a neurophysician, they immediately contacts, and this person, while on duty, guides the person what to be done, what not to be done. So if you want to reach, as sir told of Hippocrates, so if you really want to reach to the periphery, to the people, to provide the nephrological guidance, you can think of really a setup or a facility which can really be long-lasting and far-reaching and will be benefit of the people. Thank you, everybody.
Thank you, sir. Thank you for your kind words. Now I would request our guest of honor, Dr. H.S. Pathak, sir, the President of the West Bengal Chapter of API, to say a few words.
Morning, respected medical education, DHA, Dr. Banerjee,
इधर सो रहा है इधर से ये थोड़ा सा ये अपडाउन पहना हूं ना थोड़ा सा है और टच कर रहा है तो कंप्लीट रेंज है
respected Director of Medical Education, Director of Health Service, Professor and Health Department of Nephrology, IPGMR, or Secretary from API, Professor T.S. Karmakar, Professor Arpita Rai Chaudhary, and all members in the audience. We are glad and thankful that Indian Society of Nephrology has joined hands with API West Bengal chapter for organizing this program. In fact, cases of nephrology are on rise so enormously that all internists should have the basic knowledge as to how to detect CKD patients at an early stage so that we can halt the progression or we can manage at the initial stage before referring the patient to tertiary center. So I wish the program a grand success. The program has been formulated in such a way that will be beneficial to all of us. Thank you.
Thank you, sir. Now I would request our esteemed HOD sir, Dr. D. Shane sir, to say a few words for today's occasion.
A very good morning to everyone. It is my great privilege to welcome Professor Dr. Debashis Bhattacharya, Director of Medical Education, Government of West Bengal, and Dr. Ajay Chakraborty, Director of Health Service, Department of Health and Family for Government of West Bengal, Professor Dr. Monimaya Bandyopadhyay, Director, IPGMR System Hospital, Dr. Partho Sarathi Karmakar, Secretary, API West Bengal Chapter, Dr. Sanjay Chatterjee, Head of the Department, Medicine, IPGMR, and all other dignitaries present on the podium. We have organized this scientific program, CME, in this World Kidney Day celebration week to increase the awareness among our physicians, doctors, and students about kidney health. This year, Indian Society of Nephrology and API have organized along with us this scientific program. The theme of this year is kidney health for all and bridge the knowledge gap to improve or to better kidney care. As we know, the number of patients suffering from kidney disease increasing day by day. One WHO bulletin has shown that about 850 million people worldwide have been suffering from different types of kidney diseases, and approximately 24 lakh people every year die from advanced chronic kidney disease. So it is a huge burden on our society and healthcare system resources. So we have organized this CME to enrich our knowledge
of our physicians, our nephrologists, our students to improve the patient care service, to increase our knowledge about the recent advancements and developments in this branch of medical science, so that we can diagnose the kidney disease at its early stage and can provide better and more scientific, appropriate treatment to the patients suffering from kidney disease. I hope this effort will definitely have good implication on our patients and definitely decrease the morbidity and mortality of the patients. Thank you all.
Thank you, sir. Now, I would request Dr. Sanjay Chatterjee, sir, the head of the Department of Medicine of IPGMER, to say a few words for today's occasion.
Good morning, everybody. It's a great pleasure to have our DME sir, the DHS sir, amongst us. And I would also like to address the other dignitaries in the dais. The most important thing which I realized of late is that the enormity of the numbers of patients requiring dialysis and or specialized nephrology care, it has increased by leaps and bounds from a few years ago. So the importance of this CME, especially for the students of medicine who are present there, cannot be overstated. I would request the nephrology colleagues to make them interested in nephrology. It is their duty to make them interested in nephrology, because the importance of this nephrology in day-to-day life cannot be overstated, as everybody has said. I won't stand in between the most important quiz contest and this program. Thank you, everybody.
Thank you, sir. Now I would request to call on the podium Dr. Arpita Rajchaudhary ma'am to say a few words for today's occasion.
Respected DME sir, DHS sir, our director, secretary and president from API, and our president and secretary of International Society of Nephrology, and all other HOD of my department and medicine, and all other dignitaries present here, my colleagues, my students. The program has been brought in to infuse enthusiasm in budding nephrologists and medicine students to practice nephrology with maximum knowledge available. All our dignitaries have clearly stated that what is actually the state and how we can improve it. I agree with them at every step, and I'm very grateful to our DME, DHS and director, along with API president and secretary, for agreeing to observe this year World Kidney Week, so that we can infuse knowledge from one to other, which is the motto of this World Kidney Day call. Thank you all. I finish here, and I will not, I think there will be followed by vote of thanks from Dr. Partho Karmakar, API Secretary.
Thank you, madam. Now I would like to call upon the podium Dr. Partho Karmakar, sir, the Secretary of API West Bengal Chapter, to conclude this inaugural ceremony and give the vote of thanks.
Thank you, Dr. Aniruddha. Good morning, everybody, online as well as
offline who are present physically over here. So this is the first ever combined scientific program of API West Bengal chapter and ISN, that is Indian Society of Nephrology. So mornings was the day. Here in our first ever effort, we have got so many distinguished dignitaries on the dais and off the dais. First of all, I'm really very thankful to President and Secretary, Dr. Bhalla and Dr. Prasad respectively, to be present digitally, even being busy in their own program, All India Basis program. They have given their time from their busy schedule to inaugurate our program. I am really thankful to you too, sir. Now we have received we have got here physically another two very distinguished dignitaries. One is our DME and another, that is Dr. Devasys Bhattacharya, and another is our DHS, Dr. Ajay Chakraborty. So both the sirs, you will be astonished to know whenever we have approached them to any of our academic program, whether national or our local body program, West Bengal chapter program, in all sorts of academic program, whenever we have gone to them to invite them to come to our program, they have, with a smiling face, they have accepted our all sorts of this is really torture to them. But they have accepted all our invitation with a smiling face. In spite of their very, very busy and hectic schedule, they have come all the way from their office to be present over here physically to inaugurate this first ever joint program of API and ISN. Another very hot seat, that is our director's seat. And he is really busy for so many tricky works to maintain his institute. And in spite of that busy schedule, he has come here and physically present to inaugurate his institute's joint program of API and ISN. So, and our two very distinguished HODs, that is our Sanjay Chatterjee, Department of Medicine, and Dr. Devabrat Sen. Both of them, I know them since I am pursuing my MD degrees over here. I know Dr. Sanjay Chatterjee, I know Dr. Devabrat Sen, and I know Dr. Devabrat Sen more cordially when I was in North Bengal. So I am really thankful to both of them for coming over here physically and making our inaugural program successful. And our chairperson, sir, that is Dr. H.S. Patel. All the time, he is very, very cooperative and dynamic. Whenever I have talked to him over telephone, I know he's very busy from morning to late night, 11 p.m., 12 p.m. I know that. But still, he has accepted our invitation and has come all the way from Kollani to here to be present physically in our first ever venture of API and ISN. And last but not the least, that is Dr. Orpita Rai Chaudhary, who played the role of prime mover on making this program a success. And from the very beginning, by seeing the audience as well as our distinguished dignitaries, I guess that our first ever program will definitely be a successful program. And last but not the least, I am thankful to all the delegates present over here physically, as well as those who are listening online. I am really thankful to all of them, because without their participation, without their active participation, no conference can reach us grade of success. So with these few words, I'm really thankful to all of you to be present here physically as well as online. Now I hand over the mic to our prime mover, that is Dr. Orpita Rai Chaudhary. Orpita Rai Chaudhary, please.
With that, I announce the closure of the inauguration program, and the final quiz followed by CME may start after that.
Now, before announcing the qualifying teams, we would call upon the two teams who have a tiebreaker. They'll be coming to the first row, and we will conduct the tiebreaker questions, and after that, we will declare the qualifying teams and proceed with the final quiz. The teams comprising of Devapratim Ganguly, Anyajyoti Kundu, Shotri Ghosh, and team of Dr. Pallab Sinha, Dr. Amrita Das, and Dr. Abhinav Das. Kindly come to the first row so we can conduct the tiebreaker sets.
আমি যেটা বলছি সেটা শোনো, সাবধানে ভালোভাবে যাবে, নানা মতো দেখে দেখে যাবে, ঠিক আছে? দেখে যাবে, ফোনটা রাখো, ট্রেন থেকে নেমে অটো করবে, একদম হাজিরা অটো, ঠিক আছে? আমি তোমার যেটা বলছি সেটা শুনে আমি বলছি কথা শুনে পাচ্ছি।
This is the first question. Both teams will want to answer. Pallav and Devaprati. For correct answer, you will get +5. For negative answer, you will get -5. Don't want to attempt? Okay. Then hypophosphatemia. Very good. So this is Devapratim, get +5. Second question. Don't answer, first raise the question. Both team want to answer. Okay. So first Pallav. Cystinosis. Your question, your answer?
Cystinosis.
Cystinosis. So both can get plus 5. So would request the team members, one of your captain team come here and answer facing the audience. Okay. Third question, which of the following statements regarding lipid lowering therapy in CKD is true? Team member, one of the team member, please come forward and answer the question facing the audience. Last few seconds. Come here and face the audience.
E answer.
You want to say statins do not lower cholesterol in people with CKD. Okay. And sit. Your team want to attempt? No. Then this is wrong answer. This is the fourth question. Which diuretic will interfere with the ability to both concentrate and dilute the urine? Okay, Pallab, come face the audience.
A thiazide diuretics.
Okay, sit. Your answer? You want to attempt?
D acetazolamide.
Acetazolamide. Then both are wrong. This is furosemide. This is the fifth question. All of the following combinations have been shown to have added blood pressure reductions except want to attempt? Pallab. Devaprati.
E answer.
Beta blocker plus current. Very good. So Devapratim and his team got selected for the. So would request HOD sir to declare all the 5 teams for the final round.
Now we proceed with the final round. In the final round, there will be total 4 rounds. The first 2 will be conducted by Dr. Shobhita Dasgupta of our department, and the next 2 rounds will be conducted by Dr. Adunupal sir of our department. Now, Dr. Our HOD sir will be declaring the names of the qualifying teams.
Out of these 9 teams, 5 teams have been selected for final round. Dr. Shubhajit Das and Shobhik Mondol, this team of IPGME and System Hospital. Second is Dr. Shubhro Shankar Sen and team from Midnapur Medical College. Shubhankar Rai and team from IPGM and System Hospital. Dr. Arundhati Das and team IPGM and System Hospital. And by tiebreaker, 5th team is Dr. Devapratim Ganguly and team from Medipur Medical College. And they will now compete in the final round.
So all these 5 team members, please join us in the stage.
Rest of the quiz participants are requested to raise
So I
back.
would request the team members to start sitting from that direction. Shubhajit Das will sit from team A from that direction.
They have their prizes, participation prizes,
Yes, ma'am.
and
I would request other team members to sit back with us. You will get the academic feast and will get the certificate at the end of the program. Shubhajit Das and the team will sit from the extreme left corner. They are from Mednipur. Sorry, they are from IPGM and System Hospital. So Shubhajit Das and team, this is Shubhajit Das. Shubhro Shankar Sen. Shubhankar Roy. Shubhankar. Arundhati will sit there. And Devapratim Ganguly.
ঠিক আছে রাখো তো স্যার ওখানে যান কনসুলেট ও আপনারা লিঙ্ক দিয়ে দিচ্ছে আছে তো বলুন না
আমাকে স্যার বলছে যে এটা তুমি আমায় জানালে না লাস্ট
Starting with the final round. So here our judges will be Dr. Abhirup Bhuya. Would request Dr. Abhirup Bhuya please once introduce yourself to the audience.
Hello. Hello. I'm Dr. Abhirup Bhuya. I'm the senior resident in the Department of Nephrology, and my colleague Dr. Abhishek Kumar. He is also a senior resident, and we will be the judges for these 4 rounds of final quiz.
So we'll start with the rules. We'll have 4 rounds. First round we'll have 2 questions on fluid and electrolytes. Direct question will be going to the first team, and second team will also answer the same question. If both the team answer correctly, the second team will get bonus 5, and the direct question team also will get +5. There will be no negative marking. For second round 2 questions. These are all clinics and miscellaneous round, clue based. If the direct team can answer without clue, they will get 20 marks. With the first clue, 15 marks, and the second clue correct answer is 10 marks. If thereafter they fail to answer, that will go to the next round, and if that team gives correct answer, bonus mark will be +5. For round 3, there will be 2 questions, image identification, +10 for each question, similar bonus +5 for the next team. And round 4 is a buzzer round. The teams will be asked to press the buzzer. The correct answer will give them +5, and incorrect response will give them -2. So best of luck. So let's start. So first question will be to team A. This is your question. This is a 21-year-old woman with no significant medical history participated in a rape party on a Saturday night. Her friend recommended the use of ecstasy. The patient was dancing and drinking several cocktails, and she gradually became confused and drowsy. Unfortunately, her friend thought that her drowsiness was too much alcohol consumption, and she was left unattended. Subsequently, when she became unresponsive, she was transported to the emergency department. Her vitals were GCS E1, B1, and M1. Verbal and blood pressure was 100/60. Pulse was 120, respiratory rate is 12, saturation was 85% in the room air, temperature was 36, and her weight is 60 kilo. Her total protein 7.5, albumin 4.5, create 1.1, uric acid 3, sodium 120, potassium 4.5, chloride 85, glucose 100, osmolality is 250, and for urine, sodium is 120, potassium 30, osmolality is 500. CT of the brain done that showed cerebral edema. She received a diagnosis of cerebral edema caused by acute hyponatremia resulting from ecstasy. Which one of the following is most appropriate initial treatment for this patient? So team A will answer first and team B will also answer simultaneously. If both team give correct answer, both will get +5 and there will be no negative marking. Team A, B, answer is B. For team B,
Answer is B.
okay, then this is the correct answer. So both team get +5. Now direct question for team B and bonus question will go to team C. This is a 47-year-old man who was a heavy drinker, received diagnosis of liver dysfunction for past 5 years. He drank 8 to 10 beers per day and lived alone, reportedly in poor circumstances. Visited clinic when his family noticed gait instability. His GCS is E4, B5, M6, and vitals, blood pressure 120/60, pulse rate of 70, respiratory rate is 14, saturation is 98%, temperature 36.5, weight 59, conjunctiva icteric, and albumin 3, create 0.5, uric acid 5.5, sodium of 118, potassium of 2.8, chloride of 70, glucose of 80, and osmolarity of 260. Urine sodium 18, potassium 18, osmolarity 100. Received a diagnosis of chronic hyponatremia with mild symptoms due to beer potomania, and his serum sodium was corrected. After 24 hours, serum sodium was 132 and potassium was 3.1, and he had no other symptoms. Which one of the following is the most appropriate next step in management? So team B will answer first, followed by team C.
Audience response, chocolate is there. थोड़ा पार्ले और chocolate खाओ.
We'll restrict to 30 seconds time. So team B. Would request Dr. Tarok to maintain the time frame of 30 seconds. Please come and join with the judges.
The answer is D. Terminate the current treatment and observe the patient carefully.
Okay, then team C. Answer D. Okay, so here both team answered wrong. There will be no negative marking. Answer is E, current treatment and reload the sodium with 5% dextrose in water and desmopressin. So this is the explanation. Yes. Audience, okay, okay. Okay. So here we are showing you two guidelines. One is the United States and European guidelines. Both give 3% sodium bolus for severe hyponatremia, and for moderate hyponatremia, there is some no consensus. US guidelines say infusion, whereas European guidelines say bolus. But there is unanimity on management of overcorrection. Both say that you have to lower if the baseline sodium is less than 120 with hypotonic fluid and desmopressin. Why you need desmopressin? Because on 6 ml per kg fluid of hypotonia, hyponatremic correction, it will elevate sodium by only 2. So huge amount of fluid you have to give. So to restrict the volume of hypotonic fluid infusion, you give desmopressin along with 1 to 2 microgram every 6 to 8 hours. So this is a reference for the first two questions. So next question to team C. This is a 88-year-old man with syndrome of inappropriate antidiuretic hormone secretion caused by small cell lung cancer, was being treated with fluid restriction and urea, but his serum sodium did not improve sufficiently. Moreover, his diet related quality of life was reduced by this treatment. Tolvaptan 15 mg per day led to an appropriate improvement in serum sodium within the upper limit of correction. While initiating tolvaptan, the doctor repeatedly instructed the patient to drink water whenever he feels thirsty. At this point, follow-up visit, the patient reported he was drinking well with good appetite and an improved diet-related quality of life. However, 2 weeks later, he visited a clinic because of lethargy. GCS E4 B5 M6. His blood pressure was 100/60, pulse rate was 65, respiratory rate is 14, saturation 95%, and weight is 70 kilo. And blood picture, albumin 3, creatinine 0.9, uric acid 5, sodium 160, potassium 4.5, chloride 120, glucose 100, osmolarity 350. Urine sodium 15 millimole per liter, potassium 30 millimole per liter, and osmolarity was 120. Hypernatremia was diagnosed and 5% dextrose in water was administered. Which one of the following is the most likely cause of this patient's hypernatremia? And your 30 seconds time starts now for team C, and team D will answer later on for bonus Kumar. Tarok is maintaining time.
The answer is A. Aquaresis is produced by tolvaptan.
Okay, then for team D.
Decreased thirst in response to hypertension.
Very good. This is the correct response. So thirst is our first defense against hypernatremia. Somebody with intact thirst should not get hypernatremia. So team D gets bonus mark +5. There is no negative mark for team C. So next question, direct question to team D. This is your question. A 54-year-old man presents for the outpatient evaluation of new onset lower extremity muscle weakness and constipation. He has a past medical history of well-controlled hypertension for which he takes hydrochlorothiazide 25 mg daily. Denies nausea, vomiting, diarrhea, polyuria, polydipsia, acute episode of sweating or weight loss. He admits that a recent divorce has left him with current little motivation and poor eating habits, subsisting mostly on candy and pizza. Blood pressure is 180/100 and heart rate is 62. He appears overweight and disabled. Heart rate is regular without a displaced point of maximum impulse and lungs are clear. No edema, muscle wasting, abdominal fat distribution or stripe. Strength 3/5 in his lower extremity and 4/5 in his upper extremity. And his lab data is potassium, current potassium is 2.2, total CO2 is 32, BAN 15, creatinine 0.8, glucose 97, and aldosterone level is 3. For your reference has been quoted on the side. Which one of the following is the most likely finding on diagnostic laboratory testing? Your time starts now. First, team D will answer, followed by team E for bonus mark.
Increased urinary and plasma metastasis.
So you want to say answer is D. Okay, then for team E.
Answer A, a mutation in the gene encoding 11-beta hydroxysteroid dehydrogenase.
So question will go to the floor. Anyone want to attempt this question? There will be no negative marking. First, let's go to the audience and then we'll go to the teams. We'll come to the teams. Any audience? Yes.
Increased urinary cortisol to cortisol ratio.
You are correct, but can you explain? Hold back. Give him the mic.
Here there is hypertension with hypokalemia.
Yes. And His total CO2 is 32. That means bicarb is 32. So he has metabolic alkalosis. So how do you approach further? Hypokalemia, hypertension, and metabolic alkalosis. So, here, okay, you are correct, but explanation goes like, if you have a situation like stenosis of the artery, you will have both increased renin and aldosterone. Here the aldosterone level is low. Increased urinary and plasma metanephrine you get in pheochromocytoma. There you do not expect hypokalemia and metabolic alkalosis. And increased plasma cortisol would not explain the acid-base disturbance. You are stuck with first two options, A and B. Now, somebody with genetic problem with this 11 beta HSD will present much earlier, not at 54 years of age. This patient will have something acquired defect of this enzyme, and his peculiar dietary habit of congestion of candies and pizza was subsequently found to have lots of licorice. So that was the correct answer. So very good. What's your name? You will get one chocolate from our team.
My name is Dr. Amit Sarkar.
Okay, very good, Amit.
So a clap for Amit.
Clap for Amit.
Metabolic alkalosis can
Yes, sir.
cannot be explained by hypokalemia alone.
Sir, hypokalemia will explain metabolic alkalosis, but given the entire clinical context, hypokalemia, hypertension, that is acute. That is why you have mentioned there is no displacement of the effects and everything. And this enzyme defect patient have obtained very recently due to acquired suppression. So whatever cortisol is unable to get converted to cortisol, it will act on the mineralocorticoid receptor, and distally it will promote hypokalemia, and by MR activation it will promote sodium reuptake that will cause hypertension. So given the entire clinical picture and the blood picture, this is the scenario we are describing as acquired liquid. Yes, sir. Hypokalemia. Yes, sir. So we'll share the PPT with all the team members. You can read the details. These are all from American Society of Nephrology journals and Brenner. So next question to team E, direct question. 36-year-old man is referred to nephrology clinic for evaluation of hypokalemia. Patient described progressive fatigue and leg cramps over the past year since initiating intermittent fasting and adhering to a vegetarian diet. He takes magnesium supplements for the leg cramps but denies using any over-the-counter medication, herbal supplement, or illicit drugs. The patient is sexually active and is taking pre-exposure prophylaxis, emtricitabine, and tenofovir to prevent HIV. He is afebrile, blood pressure 120/80, pulse is 80, and respiratory rate is 16. Results of physical examination are unremarkable. Sodium 138, potassium 3.4, chloride of 114, bicarb 15, BAN 28, create 0.6, glucose 92, uric acid 2.3, phosphorus 1.9, and urine pH of 6, 1 plus protein, 2 plus glucose. No active sediment. The patient was admitted in an IV hypotonic saline solution, 0.45% NaCl containing 75 milliequivalent of bicarb was initiated at a rate of 1 milliequivalent per kg per hour. Spot urine and simultaneous plasma electrolytes were obtained to measure fractional excretion of bicarbonate. Your question is, what would you predict as the expected trend and values for pertinent laboratory data shown in the next series of choice after the patient received this fluid and bicarb infusion? Here, 4 options are below. Team E, your first response followed by team A.
Option B. D. Plasma sodium decreased, bicarbonate increased. Plasma potassium decreased, plasma bicarbonate increased, uric pH increased and fractional excretion of bicarbonate 15%.
And
D.
So both team get +5. So we'll ask team E, can you explain little? As was it's your direct question.
Yeah. The patient was receiving half NS.
What is your diagnosis first? In this patient? With blood glucose of 92, he has 2+ glucose in the urine and 1+ protein.
Diabetic nephropathy.
You say diabetic, he is glucose of 92. This is proximal artery Fanconi's that he was receiving tenofovir. And once you start giving bicarb to this patient, what happens next? Exactly, you get this option that once you start the bicarb infusion, your plasma bicarb will go up, but this bicarb will start losing in the urine along with potassium. So plasma potassium will dip further. Due to bicarbonaturia, you will get high urine pH and fractional excretion of bicarbonate will be high. So you are right in your assumption. So both are getting +5. So next question to team A, question number 2. For the first round, which of the following statements about renal hypokalemia is incorrect? Your time starts now.
D.
So team A answer is D and team B. It is incorrect, you have to find. Team B. You want to revise your question answer? Try.
B.
Your answer is
B.
B. And team B answer is team B. Your answer?
Answer is D.
You want to say D?
D.
So question will go to the floor then. Anyone from the audience will like to answer? You can attempt. Yes. वो आगे थी इसको कितने?
Answer is C. Artery determinants, sustained normal potassium levels can be easily achieved with oral supplementation.
So what's your explanation?
Until the metabolic alkalosis is corrected, it cannot be.
Until the option is sustained normal potassium can usually be achieved with oral supplementation. So your explanation is what?
Metabolic alkalosis until it's corrected, it cannot be.
Your answer is correct, but explanation goes like this: that in contrast to barter, in gentlemen, your TGF mechanism remains intact. So once you correct the salt depletion, you correct the potassium for the patient. And renin axis is hyperactivated, so COX-2 suppression is commonly done as the team A first attempted. That was with the NSAID is the drug of choice in neonatal barter syndrome. But here the answer it was incorrect because in barter and gentlemen you can never achieve the normal potassium level. Whatever correction of potassium alkalosis you do, because patient underlying defect remains and patient will continue to lose in the urine. So your target will be around 3.2 levels of potassium, and that is also guideline recommended. So the problem with that option was it was saying that sustain normal potassium level. This target is something that can never be achieved in patients of Bartter or Gitelman because underlying urinary losses persist. So thank you, Pallav. Pallav will get one chocolate from our team. So next question for team B, question 2. You are following up a 71-year-old man for CKD. He has long-standing diabetes and hypertension, GFR of 32, and his ACR is 1.7 grams. Potassium is 5.8 and takes lisinopril 10 milligram daily. Which of the following is the best approach to the management of his hyperkalemia? Team B, time starts now. Team B, your answer.
Answer is B.
Answer is B. And for team C?
B. B for ball.
Then again, it will go to the audience. Anyone? Yes. Oh, आगे बढ़ हाथ तो लिखो अनिरुद्ध. What does it like? Is it option B at fludrocortisone? No, that's not correct. And here another.
It's option C, initiate atropine to allow continued treatment with RAS inhibitors.
Okay, then how do you justify your statement?
Because the patient is having significant protein edema, which has to be treated by a renin-angiotensin inhibitor, and to continue to management of hyperkalemia, to keep the potassium below 5.5, we have to go with the potassium binder to treat the chronic hyperkalemia.
Very good. So he has answered also very well. So correct explanation, because AC inhibitor, these are all drugs that have shown to reduce both morbidity and mortality. We always should try to continue this medication. And we have also trial data. This is Amethyst DN trial data that patient on RAS-I who do not tolerate this drug due to hyperkalemia, when started Petiromar, they maintain the potassium level up to 52 weeks of trial phase. So very correctly answered, you will get one chocolate.
Thank you.
Please introduce yourself.
My name is Pranavananda Pal. I am from Department of Medicine, IPGMEA.
Very good. Yes, sir. Yes, sir. 32 GFR, sir. So team C, question number 2 for round 1. 43-year-old man with ESRD presents to the local emergency room complaining of bilateral lower extremity pain that began shortly after his hemodialysis session 2 days ago. He has a history of alcohol and cocaine use, but states that he has been abstinent since he was diagnosed with severe esophagitis 2 months ago. Produces almost no urine, no history of seizure, trauma, or strenuous exercise. Medications are pantoprazole, sucralfate, calcium carbonate, tramadol, epoetin, and heparin at each dialysis session. Afebrile, blood pressure of 105/47, and heart rate of 85. The physical examination is unremarkable with the exception of some generalized tenderness to palpation of his lower extremities. In addition to the history of alcohol use, which of the following is the most likely contributing factor to this patient's elevated serum creatinine kinase level? Your patient's lab values are on the right side. Creatinine kinase for this patient was 5972, albumin was 2.3, total CO2 of 22, potassium of 5.4, his hemoglobin was 9.2, and other lab test phosphorus was 2.5, and toxicology screen was negative, and thyroid tests are normal. After HD session, Patient running to emergency with acute bilateral lower limb pain. And lab showing potassium 5.4, phosphorus 2.5, albumin 2.3, creatine kinase 5972, calcium of 9.2, and rest of the other tests are almost normal. So team C, your first response. Team C.
Answer is C, aluminum toxicity.
Aluminum toxicity. Then team D for bonus mark.
Answer is D, hypophosphatic.
Okay, team D is correct. Team D will get +5, no negative mark for team C. So post dialysis also his phosphorus is 2.5. You expect that after dialysis, once you remove phosphorus from the blood, due to intracellular shift, serum phosphorus will go up. But even after going up, his phosphorus was 2.5. And remaining options like hyperkalemia would not precipitate any form of myonecrosis. Aluminum toxicity, he is no such clinical picture in this patient that can predispose him to aluminum toxicity. Vitamin D deficiency, acute such picture is not possible and not with tramadol. So team D is correct with hypophosphatemia. Next for team D, direct question. Question number 2. 79-year-old woman with COPD, type 2 diabetes, stage 3 CKD, admitted to the ICU 2 days ago with severe sepsis from a urinary tract infection. On arrival, she was profoundly hypotensive. Blood pressure improved with IV fluid, received 2 liters normal saline, another 4 liter in the ICU. Blood pressure 94/58. Intubated and sedated, oxygen saturation is 96% while receiving 30% inspired oxygen with PEEP of 5 cm, rate 20 and tidal volume of 300. Lungs are clear, she has no edema, receiving normal saline at the rate of 100 ml per hour. Following labs are obtained after 48 hours. Sodium of 142, potassium 3.5, chloride of 113, total CO2 17, blood urea nitrogen of 18, creatinine 1.4, albumin 3.6, calcium 9.4, pH 7.32, PaCO2 of 34 and PO2 of 90. What is the most appropriate way to manage her acidosis? Yes, you can answer.
Answer is B, check the serum lactate and ketones.
And for team E, bonus mark. See, okay, then it will go to the audience. Anyone from audience want to attempt? Yes, again, Vijay.
The answer is D, change intravenous fluid to ringal lactate.
Very good.
And the explanation is the patient having resuscitated with very much of IV normal saline, which has been created hyperchloremic metabolic acidosis. And to correct that, in this patient, PCOT is normal, those despite being COPD. So to treat this hyperchloremic metabolic acidosis, we have to change the IV fluid to ringal lactate.
Exactly so. This is the right choice. That NS due to yes. So Pranav is correct. You'll again get chocolate from us. That we have to exchange our fluid from NS to ringer's lactate. This acidosis is due to hyperchloremia of normal saline that induces acidosis if you give too much of fluid in a short span of time. For team E, round 1, question 2. 84-year-old man evaluated for hypernatremia. He has COPD, been admitted to the ICU with toxic megacolon due to Clostridium difficile. Treated with metronidazole and enteral vancomycin, but had a poor response and subsequently underwent a partial colectomy. Post-op, he was unable to be weaned from the ventilator and nutrition supplement being delivered via nasogastric tube consisting of 2 liters per day of tube feedings containing 725 milliosmol per kg plus 200 ml of water every 6 hours. He produces 2.8 liters per day of urine On physical examination, blood pressure is 122/64, heart rate is 84, weight is 80. There is no edema and heart examination is normal. Lung examination reveals an endotracheal tube in place with coarse breath sound, and abdominal examination is significant for a midline abdominal incision that is healing normally. Which of the following you think most closely approximates the electrolyte-free water clearance for this patient? His labs are on right.
For time constraint, explanatory slides will not be spoken about.
-8 liters per day,
Communicated in
and
the
for
WhatsApp
team
group
A,
of participants.
Negative 0.8 liter per day. C.
option C. Answer is 0.8 liters per day. That is the first choice is correct. You are correct in calculating, but you missed out with the plus and the minus mark. So no one will get the score. So we'll move with the round 2. Due to time constraint, we are not going to the details of the explanation. This is clue based. So team A will get all the clues first. If they fail, we'll go to team B. So your question for round 2, question 1, 26-year-old woman with no medical history presents to the emergency with dyspnea, vomiting, and altered mental status. Unable to provide a reliable history, BP is 120/76. Physical examination is normal, apart from generalized muscle weakness and decreased deep tendon reflex. Lab on admission revealed the following. And what is the most likely cause of this acid-base abnormality you think of? Sodium is 133, potassium 2, his bicarb is 6, creatinine 1.2, albumin is 3.6, and osmolarity is 285, pH of 7.15. For team A. Bicarb, total CO2 is bicarb. Team A.
Ketoacidosis.
Your first clue is you have a acidosis, that is you calculate the anion gap and assess whether your patient has a mixed acid base disorder or pure one acid base disorder. His sodium 133, potassium 2, chloride of 111, bicarb of 6. What is the anion gap you found? Delta delta is anion gap by bicarb. So you first calculate the anion gap and then delta delta. You will get the answer from there. Your patient has a what? Normal or high anion gap? So this is the final clue we have provided. So we'll move to team B. Team B, you answer.
Ethylene glycol toxicity. D.
No, you are wrong. Team B. Bonus will go to the only the next team. E? No, sorry, it's toluene. Patient has a mixed acid base, high anion gap and low normal anion gap acid base disorder, and this. So explanation I have written there. I will share the slide with you. Now, for team B, this is your direct question. 16-year-old boy evaluated for acute gout of his right fast metatarsal. He reported recurrent gout attack since age 14 and had been treated with allopurinol and NSAID. Brother had been diagnosed with chronic interstitial nephritis by kidney biopsy at age 18, and his father, uncle, and paternal grandfather also suffered from gout and CKD. Patient is normotensive. Physical examination is normal, except for findings of acute inflammation of the right fast metatarsal joint. And which of the following is most likely to have a pathogenic mutation in the family? His creatinine is 1.6, uric acid is 11, ultrasound normal, and urine is also normal, no proteinuria. Want to get clue? Your first clue is this patient urine blank, creatinine 1.6, a diagnosis of chronic interstitial nephritis, and we make a diagnosis of family history of dominant tubular interstitial kidney disease. Your answer?
Answer is B.
B. Okay, then for team C will get chance to answer first. Team C.
Answer is E.
UMOD. Correct. This is the correct response. UMOD has a history of gout followed by CKD, and MUC1 first CKD presentation followed by gout. So next question will go to team C. Direct question. 10-year-old girl seen for follow-up of severe hypokalemia and metabolic alkalosis occurring in conjunction with an episode of nausea and vomiting. Treatment consisted of electrolyte and volume depletion, and the vomiting resolved spontaneously over 24 hours. History includes sensorineural hearing loss since birth. Her first cousin has similar symptoms, but no other relatives are affected, including 3 siblings. Examination reveals low normal blood pressure and an enlarged thyroid gland. Lab reveals normalization of the previous hypokalemia, hypomagnesemia, and metabolic alkalosis. The urine specific gravity is 1.020. Which of the following diagnosis is the best explanation of findings in this patient?
Pendant syndrome.
Very good. So team C gets very good. So team C gets direct 20 marks without clue. Next, team D direct question is 70-year-old woman with a history of chronic low back pain, alcohol use, chronic obstructive pulmonary disease, and breast cancer presents with nausea, vomiting, and progressive mental deterioration over 5 days. Her home medications include digoxin, furosemide, and acetaminophen as needed for chronic back pain. Uses cigarettes and drinks alcohol, but is unable to say how much. Physical examination: 110/60 blood pressure. Respirations are deep and rapid. Findings include cachexia, confusion, and lethargy. Labs are as below. Which of the following test is most likely to identify the cause of her acid-base disturbance?
Time's up.
Team D.
It's ethylene glycol.
Your first clue is this patient identify the anion gap, and you calculate the delta and notice the osmolarity as well. one second clue. Your time's up. Second clue is she has chronic back pain and was on acetaminophen, furosemide, digoxin for quite some time.
C.
Yes, very good. This is paracetamol related 5-oxoproline problem. We'll go for the explanation later on due to time constraint. And for team E, direct question is 56-year-old man with CKD stage 4 from IgA nephropathy seen for routine follow-up has been feeling well, working full-time as a hotel manager and experiencing no limitations in his physical activities. He has not experienced gross hematuria, pain, skin rash, or leg swelling since his last visit 4 months ago. Takes lisinopril, furosemide, atorvastatin, and fish oil as prescribed. BP 125/85, heart rate is 76, and heart is regular, lungs are clear, abdomen is soft and non-tender, no edema, and skin is normal. In addition to recommending the dietary changes, which of the following is most appropriate initial management of his elevated parathyroid hormone level? His labs are as below. Create 2.7, phosphate 7.5, calcium 8.4, PTH of 385, vitamin D of 32. Your first clue is patient has Sinacalcet is not correct. 56 years, CKD stage 4, phosphorus 7.5, near normal calcium, and vitamin D levels are adequate.
Time's up.
You want to answer? Yes, correct. So first we have to correct the phosphate, then we'll address the PTH. So they have answered after second clue. So we'll go to the image round with Dr. Atunupal sir. Due to time constraint, we are restricting few questions.
So who is the scorer? Please mention the score. What is the status after completion of second round? So we'll move on from a brainstorming session to a more lighter round of the quiz. That is the image session. So here you'll get 2 images in a single slide. You have to answer both the part. So for each image, you will get 10 marks each. So total will be 20. So if you can answer one, then you will get 10. And if you cannot answer, the question will be bypassed to the next team. And if they can answer, they will get bonus mark as 5 for each image. So marks, please.
The scores after round 2. Team A scored 10, Team B scored 5, Team C scored 25, Team D scored 20, and Team E scored 15. So Team C is leading with Team D and Team E in the second and third spot.
So after this close contest, so we are going to the first question. So here you can identify 2 parts. Team A, for Team A. The first is one, you can see a newspaper cut where a person is lying down and there is a news. What is that? And next is means what is the procedure going on? And next is who is the person responsible for this whole procedure that come up in the newspaper.
Scientist was a William Clough. With artificial kidney dialysis.
You just you're hearing William Clough, and this is the first ever dialysis, successful dialysis that is going on with a rotator down dialysis machine. It's a big hand for the team A. Again, you can see a person demonstrating something, and in the right side you can see foot showing something coming out and again entering into the foot. So First is identify the person, and second part is identify the process, or you can name the thing what is introduced within the body part.
Second picture is the showing AV fistula, catheter AV fistula.
Next. Person. If you can name the procedure or the instrument, then you can name the person. This is the clue. So your time is up. Question pass to Team C.
Joseph Moody.
No.
Procedure হলো মানে
What is there? Procedure is done.
There is a loop, right? Something is coming out from the.
মানে AV fistula ফার্স্ট করা হয়েছে.
No, that is not AV fistula. Next. Yeah. Team D. No. Team E. Team A. So after William Goff, you need to have something for which you need to have access for going for dialysis. But that time, it was very difficult. So a person, the real inventor, identified or discovered this process. And now question goes to audience. So the scientist or the surgeon is a Scribner, and it's a Scribner shunt. It is a memorable discovery in the history of nephrology. Next question. This goes to Team C. Identify the thing that is holding the hand of this person, and again the name of the person. And this is again a revolutionary discovery in the history of nephrology per se, in the history of transplantation. Before that, whatever transplantation done, the transplantation was not successful. All the transplantation were not successful.
Is there any picture?
No. You need to get a specific answer. We need a specific answer. So, Pasha should take D. Here, I want exact answer. Yeah, they are close, but I want exact answer. Team E, no, ma'am. Lots of other teams are there. Team E. No. A.
Immunofluorescent test for
Team B. Question goes to audience. Anybody? Sir. No, sir. Obviously. Yes, sir.
No. I also say something.
Yes, sir.
Somebody who said HLA, somebody who said on this line, they were partially correct.
Sir.
It's not expected that they will come to the CDC, what you are reading. That's what HLA is, I think, a good answer. Also, AV fistula was a good answer.
Sir.
I mean, they will not be able to differentiate between shunt and fistula.
Sir.
They are not yet into nephrology. If they're MD students, then I think they should be the one who said fistula. In my mind, should get half the point, and even here also.
Sir, we can consider, but the thing is there is a quiz competition. So if anybody could answer, then they should get the full marks. That's why I can consider. But HLA, it's okay, but still cross match. This terminology I want to hear, sir.
HLA, that thing will look exactly the same.
Yes, sir. Yes, sir. So I want to hear the answer cross match, this terminology. Cross match. Next question. Again, you can see two parts. One is the person, and another a person doing something on a cow. So again, revolutionary discovery in the history of transplantation, renal transplantation, or rather say transplantation, and the person got Nobel Prize for that. Question four?
William C. Murphy for first transplantation.
No. No. Next team. This is again related to immunology, transplant immunology.
Allografting.
Anything more? So this related to immunology, so that the rejection should not occur. So identify whether this kidney or organ should not get rejected from the body. So is the person any procedure means can you name anything, any word that is close to this procedure? Describe, can you describe the thing that is going on? Next thing.
GVHT, graft versus host.
Here, but still not matching what we are expecting. I'll come to you.
To take a hypersensitivity reaction.
No. Next step.
Xenograftic transplantation.
No. Team C. So again, I'll come to team D. Please answer. Yeah, I'm coming because this is really a tougher one. Okay, the sir, Dr. Dotto has already told me. I may not be on number, but I will hear the answer.
Is it the process is intolerance?
Right. If you can name the person, then I can give you a number. So anybody from the audience?
Skin grafting was.
So this is a Peter Meadow, and this is a revolutionary discovery again. Because if you put something that in the organ, it's in the body, and that organ is not rejected from your body, this is the most important thing in the transplantation procedure. So your body will tolerate the organ. That is called immunologic tolerance. So this is a real discovery again. Next question to him. E. So identify both of the person. So you have already got the clue that the first kidney transplantation. I am giving you another clue that they are the surgeons. Well, pass. CME.
William Brothers key.
No.
Similar.
No. First kidney transplantation. Two surgeons.
জিম বার্গার আর ব্রেডিক ব্রাদার্স এর করেছিল আর
Which brother?
ব্রেডিক ব্রাদার্স
No.
আর জিন হ্যামবার্গার মানে সার্জনের নাম
No.
এটা ফার্স্ট কিডনি ট্রান্সপ্লান্ট মানে যেটা সাকসেসফুল হয়েছিল না প্রথম যেটা করা হয়েছিল জোসেফ মুরে তাহলে ফার্স্ট যেটা সাকসেসফুল হয়েছিল জোসেফ মুরে আর না জোসেফ মুরের সাথে করেছিল আরেকজন এই থমাস
Another plastic surgeon.
হ্যাঁ না মুরে ব্রাদার্স নাই জোসেফ মুরে আর তার সাথে
জোসেফ মুরে
No. TV. Anybody from audience? obviously they will get the half marks. Team C +5. Audience.
But I think they are the donor and the recipient, they are not the surgeon.
Pratik,
they are the donor and the recipient.
No, brother-in-law, sir. What a Herrick brothers. No, sir, surgeon. Mare are হচ্ছে মেয়ে। Pratik দেবতা বলছে।
I think Pratik is saying the same thing.
Chobita হচ্ছে donor and recipient. They are the identical twins. Herrick brothers. This is not the Mari. These are the donor and the recipient. These are the Herrick brothers.
কন্ট্রোভার্সিতে যাচ্ছি না স্যার, মানে হেরিক ব্রাদার্স তাদের ট্রান্সপ্লান্টেশন হয়েছিল, রোনাল্ড দিয়েছিল। ওকে so team C will get 5 marks. Score.
Team A scored 20, Team B scored 5, Team C scored 30, Team D scored 20, and Team E scored 50. So the last round, before Braja round, Team C is still leading with score of 30.
Pass হয়ে গেছে। কোনটা বল? এই বিষয়টা এই এক্সাক্ট টার্ম শুনতে চাইছি। This is very specific. Discovery is very specific. So the position is. So, next round is a buzzer round. Here you should check your buzzer. Each and everybody. Here, you will get a straight question. There will be no pass marks, means that there will be no bonus, and the question will not be passed on. Here, if you give correct answer, you will get +5. If you get negative, means wrong answer, you will get a -2. So be careful. Start. So which of the following statements is correct? Incorrect. Isolated proximal renal tubular acidosis without other renal tubular abnormalities is exceedingly rare and typically associated with the eye abnormalities. So proximal RTA occurs most commonly in the context of generalized proximal tubular dysfunction, that is called renal Fanconi syndrome. The hypercalciuria in distal RTA is due to an associated defect in tubular calcium excretion, and distal. Somebody else raise the budget. Yeah, you can.
Team C.
Team C.
Distal RTA can be effectively treated with alkali supplement.
So, yeah, you can. It's already displayed in the thing. So -2 for Team C. So over excitation is not proper. Next question. Which of the following is now known to play a dominant role in modulating the activity of the thiazide sensitive NaCl transporter in the distal convoluted tubule? A. Serum potassium concentration. B. Serum sodium concentration. C. Serum chloride concentration. D. Serum bicarbonate concentration.
Team D. Team D.
Again, a wrong answer. It is serum potassium concentration. So if you once you press it first, so you will get the first this light on. So nobody again press the button. It's everyone on.
Sir, cheering এর গ্রুপে তিনজন করে আছে।
So on to next question.
মেডিসিনের যিনি
Number 3. All of the following statements are true about the initial dip in EGFR after initiation of SGLT2 inhibitors, except the decline in EGFR is reversible. Number B, it is observed even in patients with non-diabetic kidney disease. C, it can be TMA.
Option C. It can be due to natriuretic effect causing tubular glomerular feedback.
So again, wrong answer. So it is linked with higher chances of AKI in future. It's not true. The chances of AKI occurs initially, not in longer term. So again, negative marks.
Second can first.
Fourth question. Maya, 35 years old female presented with acute onset flaccid paralysis of bilateral lower limbs. There is no sensory neuropathy. A BP was 100 by 70 millimeter mercury. Investigation showed serum sodium 136, serum potassium 1.9. Again, TMA.
Sir, আপনি আমার টপিকে চলে আসুন কি হয়েছে?
Yes, correct answer. So TMA will get full marks. Number 5. Which of the following is not the cause of hypokalemic metabolic alkalosis with hypertension with low aldosterone? A. Cushing syndrome. B. Liddles. C. Licorice ingestion. D. Glucocorticoid remediable aldosteronism. Team C. Okay. It is already discussed.
Cushing disease.
Cushing's disease. So you can see the result. So again a wrong answer. So you will get a -2. So that you can do. It's a Bajaj system, so it's open. So this happens. It's a strategical move. This happens in quiz. Yeah, this can be. Right. So once you press your buzzer, that means you are the winner. Means you have to answer. It can be either wrong, it can be either right. So it is actually a last round. Here it is a strategic move that you can do, and that is usually done in everywhere in the quiz. So wrong answer got -2. So that's all. You just calculate the total marks. Number 6. All the characteristics of CKT-U, that is unknown, except a urinary loss of magnesium, phosphorus, and potassium can occur. Number B. Environmental and occupational factors are probable suspects. Urinary levels of beta-2 microglobulin and NGAL can be elevated. And number D. Oliguria occurs early in the disease. Okay. So +5. Team B +5. It is more of interstitial type of nephritis, so oliguria occurs late in the disease course. Number 7. All of the following are contraindications for tolvaptan except pregnancy and lactation. B. Polycystic liver disease with normal renal function, liver function. C. Urinary.
Team D.
Team D. B is a correct answer. That is polycystic liver disease with normal liver function. Very good. Next question. Number 8. Mutation in which of the following gene has highest
Team B.
post-transplant ages? You have to answer. Wrong answer. It's CFB, complement factor B mutation. It's more or less 100% recurrence rate in transplantation. So, next question. True about IgA dominant post-infectious glomerulonephritis is all except Team E. It's C. C is correct. Very good. Compliments can be low in 40 to 55% patients. It doesn't matter. Next, what is recommended in supplemented very low protein diet for chronic kidney disease? Even. C. C is a correct answer. So get full marks. So here we are concluding our quiz. Scorer, please calculate the scores. Sir.
I think this answer.
The exact word will be ketoanalogs.
Ketoanalogs.
Not ketoacids or ketoamines. Ammonia to be excluded. Ammonia.
Sir.
So this is wrong.
So meanwhile, the scorer calculate the final mark sheet. Here is a question for the audience. In preeclampsia, true is, but except is increased SFLT PIGF ratio, B decreased PIGF, C decreased serum endocrine, D increased glycosylated fibronectin. So this is a really a tough question. So goes to audience. So we can see what somebody has raised.
Nephrology can participate if past medicine.
It's C, decreased serum endocrine.
So it's a correct answer. Here in preeclampsia, you will have decreased serum endocrine. What is your name?
Love to get you in nephrology, dear.
Thank you.
Introduce yourself.
I'm Dr. Prabhavan from Department of Medicine, IIT.
Oh, a big hand for him. Marks ready? Scorer, please come here and you announce the marks.
The final score after all the 4 rounds, Team A score of 28, Team B score of 8, Team C scored 26, Team D scored 23, and Team E scored 20. So the third team is Team D, the runners-up is Team C, and the champions are Team A.
So here we conclude the session of quiz. It was a really exciting game, and yes, we'll distribute the prize and the certificates after the program is over. It's a deliberation session. Okay.
Good afternoon, everybody. So I congratulate all the teams, quiz teams from various medical colleges for their active participation and competition in quiz contest. It's not very important to have won the match, but it's very important that you all have competed and all the time you take, very much enthusiasm to be one of the candidates in all sorts of quiz contests. So I congratulate you all, and your winning prize money will be given in our valedictory session. So please sit back and listen to our academic programs. Then in valedictory sessions, the first prize, second prize, and third prize, 6,000, 4,500, and 3,000 will be offered for giving you more enthusiasm for next time competition. So thank you all. I thank to all the teams for joining in this competition. Thank you.
Thank you, sir. Now to continue with our technical session, the first session is on urine routine and microscopy, a very simple but most essential tool for the nephrologists. And for this session, I would like to call upon the stage the chairpersons, Dr. Devobroto Shein sir, our head of the department, Professor Dr. Soumitra Ghosh sir from the Department of Medicine IPJMER, and Dr. Partha S. Karmakar sir, Professor of Medicine from the College of Medicine Sagar Datta.
All the dignitaries are also requested to collect the lunch bag.
So good afternoon, everybody. So welcome you all to this excellent program on this auspicious day. So now we are starting the scientific session. This next program is urine microscopy. Is it a liquid kidney biopsy? Very interesting topic and a day-to-day practice for all the clinicians and the nephrologists. It is very important. And the topic will be delivered no other than Dr. Pratik Das. Dr. Pratik Das does not need any introduction to this august gathering. He is a very well-known nephrologist in our city, in our state, and in India as well. We are very proud that Dr. Pratik Das is an alumni of this institute. He completed his postdoctoral course in nephrology in 2005 with reasonably satisfactory academic record. Since then, he has been practicing nephrology in Kolkata with reputation. He runs the large volume renal transplant center in Kolkata in R.N. Tagore International Institute of Cardiac Sciences, and he has performed more than 2,000 renal transplantation, which includes disease donor, live donor, swap, and the ABO incompatible transplantation. He works as a senior consultant nephrologist in our city and as a teacher for DMB nephrology program and as a dialysis technician as well. His special area of interest is the ABO incompatible kidney transplantation. He has multiple papers in national and international journals. He was awarded the Bonsall Award for Young Nephrologist in 2009. He became the Fellow of the American Society of Nephrology in 2017 and the Fellow of Indian Society of Nephrology in 2019. I would think that the list will not be completed within a very short span of time. So without wasting much of time and without going for the other details in his career, I will request Dr. Pratik Das to start the deliberation of this very important clinical issue. This unit microscopy, is it liquid kidney biopsy? So Dr. Pratik Das, please.
Thank you, sir, for this nice introduction. At the outset, I would express my pleasure to be here, my institute after a long time. In next few minutes of time, I will be talking something which is not very much practiced, but should be practiced, which is called urine microscopy. Today's topic is in the liquid kidney biopsy. So whenever we deal with the patients of kidney disease, apart from the history and the clinical examinations, we do the blood parameters, both renal function and immunological, that is target oriented. We do the imaging studies, starting from ultrasound to so on. And we did do the urine analysis and the renal biopsy, and also the recent introduction is the use of biomarkers, that is the proteomics. Amongst these, the renal biopsy is the most invasive way, and that gives the real picture of what is happening within the kidney actually. So there has been repeated effort to replace this invasive method, to replace by something which can tell us which is happening in the kidney by doing other tests. And one of these is the urinalysis. So urine microscopy is the first one to be nurtured way back, and it is used as a first surrogate marker of the kidney diseases. So the history tells that the examination of the urine was initially done in 13th century. Till now, in the late 20th century, it was practiced. Only thing is that there's addition of microscope, addition of some chemicals to stain the kidneys microscopy, and the dipstick test is available to complement this microscopic testing. Before microscopy, it was also practiced, but the birth of the microscopy with the development of the microscope in the late 1580 to 1700, actually this kidney, this urine microscopy started. And after that, there is a stasis of the period because of the development of, because of the non-availability of the adequately or the perfect lenses which could describe the adequate picture. But these hindrances are elevated in the around 1810 to 1840, when the first time this advanced lens are achieved, and we got the microscopy testing done very efficiently. The urine sediment was first described in 1840 to 1900, and with the different stains, it became much more attractive. Till the new development in last century, that there is optical microscopy in the picture, there's phase contrast microscopy, and at the same time, there is a huge development, that is the machine replaced the man, that is development of automated system of the analysis of the urinary sediment. So the urine examination has gone through a long history, and the utility differed in time from time to time. And still in the nowadays, which you are getting in our reports of the urine examination, basically done by the automated tests, by the machines and the technicians, not by the trained nephro or the nepropathologist. So is it still relevant nowadays with the development of so many things, including the biomarkers? I can recall a history of one of my patients, a 55-year-old woman with a history of diabetes and hypertension, attended the OPD for the evaluation of edema. She had a normal renal function, slightly lower albumin, bilateral normal sonological kidney, and urine examination showed a 2+ albuminuria with 2 to 3 RBCs, no RBCs, or only 1 or 2 pus cells. So is it very relevant? When do we do actually in our practice the urine examinations? We do when there is an acute and chronic loss of GFR, or there is any clinical suspicions of the urinary abnormality like the edema or the some diseases which are direct impact on the kidneys. Then we do the urinary tests. More so it is applicable. We do when we do the sediment test, actually microscopy tests. It usually done in all patients of acute kidney injury, with the possible exception that if it is a proven obstructive kidney disease, it is done in the initial workup in most of the cases of the CKD, or in otherwise asymptomatic patients, in order to clarify the significance of the finding that is seen in the dipstick test, or the dipstick test has been done due to the workup of those diseases. So in these situations, we actually do the microscopic testing. So there is the automated system versus manual system, but how much it is helpful of doing this testing in the automated era, with the era of the automatic machines. These digitalized machines, they have a well-controlled system. They take very less time. You can see this different system. This is COVAS machine takes 15 images in 30 seconds, and you can get the report within about 45 seconds of time. That is much lower than the manual examination of the microscopy, which takes about 2.5 periods to give a reasonable reports. More so, they can usually pick up the RBCs and the WBCs fine, because the sensitivity and the specificity and the correct result of getting WBCs and the RBCs in manual versus automated system is around in more than 90% cases correlation, but they are very poor in detecting the epithelial cells. That's the important implications. And at the same time, they are also very poor in detecting the casts. So in those two specific situations, which has got an important implications on the kidney diseases, we need a nephrologist or a nephropathologist for the detection of these things. In the sediment, what do we see actually? See the cells, cast, crystals, microorganisms. And we get it with the different kind of staining techniques. We get the RBCs. RBCs are basically comes in the urine, either maybe a glomerular barrier breaking or maybe any part of the urothelial tract. It is more so visible if you use a phase contrast microscopy. The two things are important, whether these are monomorphic, like you are seeing a blood sample, blood smear. If you see same thing in the urine, that means it is coming from anywhere in the urinary tract, may not be a glomerular disease. But if you get some amount of the dysmorphic RBCs, this morphology is not isomorphic, this is dysmorphic. Maybe very few percentage, less than 1%, less than 5%. It indicates that it is coming through the glomerular breaking, the glomerular barrier, indicating thereby there must be some proliferative glomerulonephritis. WBCs, but not that specific in terms of detecting the kidney diseases, be it a neutrophil, be it the eosinophil, be it the lymphocyte. They have been highlighted in different points of time. But it is found that the correlation between the diseases like interstitial nephritis, pyelonephritis, glomerulonephritis, their correlation is much poor compared to the WBCs, compared to the RBCs. These cells usually we do not discuss much. It is not much reported in our reports of the automated machine generated report. These are called renal tubular epithelial cells. But these cells basically makes the urine examinations with the kidney biopsy much closer, because if you get much more number of the renal tubular epithelial cells in your smear along with this is epithelial cell cast, it indicates that there is a recent and significant tubular damage. In cases of the acute tubular necrosis, where we get nothing or minimal abnormalities in the biopsies, here this kidney urine examination can give us a huge clue. And here basically the kidney biopsy and the urinary liquid biopsy, they come closer. Now this is not true for the other epithelial cells like the transitional epithelial cells or the epithelial cells of the lower tract. At the same time, suppose the patients we are getting is an incidentaloma within the kidney, and you are getting these urinary malignant cells. That can avoid even the kidney biopsy, because with an intact capsule, if you do a biopsy and your PET scan report is facilities are not available, then it's very difficult before surgery or before nephrectomy to get whether it's a malignant tumor or a benign tumor. So in those situations, urine microscopy basically eliminates the need for a biopsy. So these are some abnormal cells found in special situations, so that the history is important. This is the viral inclusion bodies. Here we get some viral infections in the kidney, particularly in the post-transplant scenario. Along with these cells are the WBCs, RBCs, and the epithelial cells. The casts are important. These are basically proteins secreted by the tubules, and when they are going through the tubules, in normally flowing urine in the tubules, they do not form. But if there is some stasis, they are formed. We call it a cast. The basic cast is a hyaline cast. That is only the proteins. If the RBCs gets attached to it, is the RBC cast. That is found very much specific of that with glomerular disease. Even if it is isomorphic RBC get attached to this hyaline cast, we call it a RBC cast, and that is important for the diagnosis of proliferative glomerulonephritis. It can be a WBC cast with non-specific importance. We get in glomerulonephritis, pyelonephritis, interstitial nephritis, vasculitis, anything. And this is important that I am again emphasizing that renal tubular epithelial cells, when you get a cast to the renal tubular epithelial cells, that indicates there is significant tubular damage. Particularly tubular damage has been started recently and quite severely. And if you get this granular cast, this means the damage has gone beyond the damage of the epithelial cell. The cells has been destroyed, the dead lysosome that is getting attached to the cast, and then give a fine granular cast. And if this granular cast damages the tubules and they become more accommodative, we get the waxy cast. So in the early phase of the damage, in the tubular damage, we can get an hyaline cast. In the later stages, you can get a tubular epithelium. In the more advanced cases, you can get fine granular cast. And this is the ultimate of the muddy cast of the tubular necrosis patients. In some patients, we can get only the fat globules, very close to the looking like that of an RBCs, but it is of different sizes. And we can get that. This is found especially in patients of lipiduria, patients of podocytopathies with much more lipids in the urine. So get crystals. Crystals are important when they are concordant because the crystals may be found non-specifically and in the initial hours. So if the blood picture suggests that there should be a presence of the crystal, that is important. But if it is discordant, there is no history of getting some crystals, the clinical importance is less. These are the different types of the crystals. I am not going into the detail that we can get in the things. Also, we get in the urine some infectious agents like the bacteria, fungal hyphae, etc. So at the end of the urine examinations, when you examine your cells, your cast, and your fats, and there can be three types of clinical scenario you can get. Number one, there is a hematuria dysmorphic RBCs in the urine. There is RBC cast with varying degrees of albuminuria. That indicates a proliferative glomerulonephritis. That will be IgA nephropathy, ANCA-associated vasculitis, or lupus nephritis. Or second group, in those cases, we get a huge albuminuria, but in absence of any hematuria or absence of active urinary sediment. That indicates a non-proliferative glomerulopathy. That may be a diabetes, amyloidosis membranous, or focal segmental disease. In one, what we call it a podocytopathies. Third, in cases we get a multiple granular epithelial cell cast along with free epithelial cells, particularly renal tubular epithelial cells. That we get in acute tubular necrosis in the patients of underlying ATN or the acute kidney injury. These are the sick patients, but kidney biopsies are not possible in those situations. These examinations are very important. Isolated pyuria is another syndrome we get in infections and some tubular interstitial diseases. So from urinary tests point of view, we can get 4 kinds of syndrome that can give you what actually happening in the kidney if you do a biopsy in the kidney. And in the other way, if you think of the clinical scenario, in one end there's a clinical scenario, one end there's a urine. In the clinical scenario, if you get a patient of pre-renal agitemia due to stasis of the urine, there is some hyaline cast, but nothing else. You can get few epithelial cells. There is no proteinuria. In cases of acute tubular injury, that is very important. Here you get a much more renal tubular epithelial cell, renal tubular epithelial cell cast, etc. But in absence of proteinuria, interstitial nephritis. In this situation, here actually the urine examination doesn't help in diagnosis the acute interstitial nephritis. So because the correlation with the WBC cast with the histological diagnosis is very poor. I have already told about nephritic syndrome, nephrotic syndromes, and the crystal nephropathies. Another one is the osmotic nephropathy. Particularly the patients are getting of the ionic contrast, or this is osmotic agents. In those situations, there is a tubular damage, but these tubular cells are basically, this is a solid type of cells. So in the clinical syndromes, you cannot do a biopsy directly. You can get a huge clue very close near to the biopsy if you do these tests in the group of patients. In the patients, so diabetic patients came after 1 month to us in our patient, and she had a community acquired lobar pneumonia with hypotension and associated with some acute kidney injury. Empirically, we treated her with ceftriaxone with azithromycin with fluid resuscitation and low dose of norepinephrine. Blood cultures grew streptococcus pneumoniae and azithromycin was discontinued. Serum creatinine, which is normal initially, goes up in the initial 3-4 days to 2.7 to 4.1. At 10 days, sepsis was reasonably controlled, but the creatinine went up. Urine analysis at that time showed the proteinuria that was previously there is persisting. There is some blood, but all are isomorphic RBCs, and at the same time there is a 10 to 12 WBCs along with some renal tubular epithelial cells. So what is the diagnosis at this point? What is the cause of this AKI? Is it ATN? Because she is showing some amount of the tubular epithelial cells. Is it AIN? Because she is showing some amount of the WBCs. Or is it post-infectious glomerulonephritis because she is showing some proteinuria, some RBCs? Probably PIGN is not because albuminuria is old and the RBCs are isomorphic and there is no RBC cast. So first 2 possibilities, actually you cannot differentiate between these 2. So it will be a biopsy in this patient, and it shows, you can see there's a dense infiltration of the WBCs in the tubular interstitial space. That means it's an acute interstitial nephritis. So ceftriaxone was discontinued, and because it is known to cause this acute interstitial nephritis, and creatinine went up to 6.5, we started prednisolone as the sepsis was controlled, and creatinine came down to 1.5 after 1 week of treatment. So why this is discrepancy? Why the test didn't pick up actually what is happening? This is happens in cases of acute interstitial nephritis. In Mayo Clinic study, they have shown that if you use more than 1% or more than 5% threshold for the eosinophils in the urine, they fail to differentiate between ATN, AIN, proliferative glomerulonephritis, diabetic nephropathy, or cast nephropathy. The idea of telling it is that in acute interstitial nephritis, the distance between biopsy and urine examination is huge, and it is closest in cases of the ATN, where cannot do the biopsy. You can see leukocyturia or the hematuria that is found only 50 to 70% cases of the AIN, and that too is not very much specific. So that is more important if there is an ATN. If there is a pre-renal, I have already, you can get an hyaline cast and small number of renal tubular epithelial cells. If there is ischemic or toxic injury already set in, then you can get a more number of the tubular epithelial cells on the cast, and you can get concomitant RBCs. This is if the tubular epithelial cast, there's a relatively recent injury. If a granular cast due to lysosomes, that's a significant tubular injury. This AKI network study, they performed a study in 2008 and 9, and they just developed a scoring system for the diagnostic and the prognostications of the acute tubular necrosis patients who are very sick in the ITU and cannot do a biopsy in these patients. This included these renal tubular epithelial cells and the cast, and a score more than 3. They have taken as a cutoff, and shown that those patients having a score more than 3 are more chances of development of worsening of this acute tubular necrosis, dialysis requirement, death. So it does not only diagnose this acute tubular necrosis, which we actually cannot diagnose in the biopsy when you can get a normal biopsy. These things can not only diagnose that, it can also prognosticate and give us a clue regarding future outcome and the nature of the disease. So the treatment of the renal function improved, and the patient creatinine was 1.4 in the follow-up OPD. She complained of some fever and dysuria, and creatinine went up. We did an urine examination because we are doing in every visit, and we got this can get this is some budding yeast cell, maybe related to contamination, maybe a UTI. We started antifungals in these patients, and then she lost to follow-up. After some time, first lockdown, she came with a creatinine of 1.4. At that time, the urine microscopy showed this kind of things. This dumbbell shaped something, we call it a crystal in the urinary microscopy, not the epithelial cells this time. I have already told, if there is a history, the crystals are important. If there is no history, the crystals are not very important. So we tried to take the history. On inquiry, she gave a history that she was taking prophylactically vitamin C for more than a year, and at the same time with the vitamin D capsule. You know, the hyperdosing of this vitamin C causes depositions of the oxalate crystals within the kidney, and along with calcium, they can give the calcium oxalate crystals. That probably happened to this patient. We immediately stopped this vitamin C, and the patient creatinine improved. These are the history you should take. These are different crystals, maybe endogenous, maybe some drugs that can cause deposited and cause a kidney damage. In some special situation, I have already telling that some cases urine examination gives us some clue, but in the special scenario, it can almost replace the biopsy. This is the cells, we call it a decoy cell, a specific viral inclusion cell found in the patients of BK virus nephropathy in the post-transplant scenario, where the biopsy you can get the SV40 stain positive BK viruses, but the decoy cell has a lower sensitivity but much more specificity towards the development of the disease. So if you do a urine examinations, it is very close to the biopsy, call it a liquid biopsy. If this is acute tubular necrosis, it's very close, not only diagnose, also can prognosticate. It is almost useless if you are trying to diagnose an acute interstitial nephritis. It is very good clue towards the proliferative glomerulonephritis or differentiation between a photocytopathy and a proliferative glomerulitis diseases. And in the presence of history, it is important in the crystallopathies. And this is also important in some, if it is combined with the newer protein mix or the biomarkers. So I can conclude my talk with telling that when a patient dies, this is not my thing. This is told by Thomas Addis as back as about 100 years back. When the patient dies, the kidney may go to the pathologist, but while he lives, the urine is ours. It can provide us day by day, month by month, and year by year a serial story of major events within the kidney. Thank you.
Thank you, Dr. Pratik Das. He has covered everything very nicely and in detail. Now I would like to add a few points. Number one is the method of collection of the urine. So proper instruction to be given to the patient, and in case of pediatric patients, their guardians, how to collect the urine. Most people has no idea. So before collection of the urine, they should be given the instruction that it should be freshly voided, clean catch, mid-stream urine. In case of male, the foreskin to be retracted back and the glands should be cleaned with clean water. In case of female also, the labia should be separated and the area should be cleaned with, preferably with clean water. And in case of female patients, they should be instructed that urine collection should not be done during menstruation or in the perimenstrual days. That urine may be contaminated with the menstrual blood and vaginal secretions. Number two is urine should be examined within 1 to 2 hours. And as most of our laboratories have the automated machines for doing the microscopy examinations, we traditionally do our old traditional method. The urine, at least 10 ml of urine to be taken in a alicot, and it will be centrifuged with a speed of 1,500 to 2,000 rotations per minute for 3 to 5 minutes. And the sediment pellet, the supernatant 9.5 ml urine to be discarded by aspiration by a pipette, and last 0.5 ml urine, supernatant urine, to be kept behind and will be gently shaked or dissolved properly by a pipette. And then from there, 50 microliter urine to be put on a clean glass slide covered by cover slip and maybe stained with methylene blue, and then should be examined. And sometimes due to contamination by vaginal secretions, you can get Trichomonas vaginalis, you can get large squamous cells and RBC. So you should be cautious about these things. Number two, during microscopy, not only phase contrast microscopy, polarized light microscope has also some role. In case of fat droplets, Maltese cross is well seen by polarized light. Then different crystals like uric acid crystals also show beautiful colors under polarized light. So these few points I want to add. And
Thank you, co-chairpersons, for your valuable comment. Now, I congratulate Dr. Pratik Das for his excellent and lucid deliberations of his topic, and he has completed his lecture on time within 20 minutes. Thank you for maintaining the time. Now the session is open for and I invite 1 or 2 questions from the house. Be very brief to your questions because we are already lagging behind by 1 hour.
In all your projections, you have shown that protein and using 2 plus. Do you think 24 hours protein is more appropriate for 1 plus, 2 plus proteinuria, or you look into only plus 1 plus, 2 plus of it? Am I communicating properly? Yes. Second is there are plenty of paper in at least conditional region that there is very bad correlation, particularly subsets of basal property, that they do not pursue correlate with the urinary setting. And Dr. Pahani has published a paper on that also. What's your idea?
So your question has 2 parts. One is the urine routine dipstick examination versus 24 hours quantification of the urine. Sometimes some tests are best, but they cannot be done properly. 24 hours urine quantification is always good. That gives you the real picture how much protein that is excreted in the urine. Often the collection method is erroneous, that it is not properly explained. The transport time is different without any antiseptic. So this is technically this is a difficult one. But if you can do, yes, it is always there. But if the patient comes to your clinic or in the hospital OPDs, in those situations, it is a very good correlation between the dipstick test and the quantification. If it is done properly, it's a good correlation. So if you have the initial screening test is fine. Screening test should be like that, which should be simple, it should be easily done, it should be cheap. So for these purposes, if you have any doubt, any discordance, then in those situations you can always do a 24-hour urine perform. But it has been shown that error in the reporting of 24-hour urine is much more than that the errors that is found in cases of this routine albumin creatinine ratio or the dipstick testing. So secondly, second part is the lupus. Yes, the lupus urinary findings are very poorly correlated, and that's why the different criteria has been put for the diagnosis of lupus patients for the biopsy, both in terms of proteinuria or the main reason I think the main reason for that is that this is a dynamic process and varied pathophysiologic process goes on at the same time. Suppose a patient of a lupus, there is a diffuse deposition of the antibodies all over, the diffuse deposition of the IgG, C3, C12, etc. But at the end of the day, he is going through a process of photocytopathy. So you get a huge proteinuria, but minimal amount of the proliferation at the same time RBCs in the urine. So there will be poor correlations. So there will be SLE's proliferative system has been more active, but a membrane leaking system is more active, but the photocytopathy is more active, but a vasculitis is more active. That gives you the exactly reflection within the urine. But how much dominant what is, that is not known basically. That's why in lupus that these things changes. Basically when you do the urine test and when you're treating the patients, there may be some gap, and by this time the process has been totally changed. There is a class shift. So probably I think this is a poor correlations of the urinary findings, especially in cases of the
Thank you, Dr. Pratik Das. Any other question from the house? And that should be the last question. If there is no more question in the house, I like to get my co-chairperson, Dr. Soumitra Bose, to conclude the session.
Thank you, Pratik Das, for the beautiful lecture. Everybody has been benefited. So I will request the organizers to move on to the next session. So this session is closed. Thank you.
House recommends chocolate free. শরীর খারাপ হয়েছে, কাল রাত্রে ফোন করেছি, বেশি শরীর খারাপ হয়েছে।
Thank you, sir, for your informative and explicit lecture. Now for the next technical session, we move to a underrated aspect of CKD management, that is nutrition. And for this session, I would like to call upon the stage the chairpersons, Dr. Arupratam Datta, sir, Director of Nephrology, Fortis Hospital, Calcutta, Dr. Sanjay Chatterjee, sir, Head of the Department of Medicine, IPGMER, Kolkata, and Dr. Udas Chandra Ghosh, sir, Professor of Medicine from Medical College.
Hello. I think we are running late, so I will not waste much time in starting the session. We invite Dr. Dipankar Sarkar, who is now the Professor of Nephrology in North Bengal Medical College. Well, Dr. Sarkar passed from Medical College in 1999, and he has been an alumnus of this institute where he did the nephrology DM and passed out in 2011. Finally, he had been at this institute in various capacities before he was transferred to North Bengal Medical College at present. He is interested mainly in CKD of unknown origin, as we say. Without much, I think Dr. Sarkar, please start.
Thank you, sir, for your kind introduction, and good afternoon to everyone. The topic of my topic is dieting CKD myths and reality. So I'll cover just 2 points where there is a lot of controversy and misconceptions among various clinicians regarding what should be the diet in chronic kidney disease. So I will discuss 2 of these aspects in my talk. So the first aspect is protein or dietary protein intake. So first question is, is it helpful to restrict protein in chronic kidney disease? So the answer, if you go by data on studies, is actually yes. Dietary protein restriction, if you increase dietary protein intake, it increases the absorption of amino acids, leads to more sodium reabsorption due to the sodium amino acid co-transporter, eventually gives rise to increased GFR proteinuria, leading to glomerular sclerosis. In animal models, it has been shown that decreased dietary protein causes a decreased afferent arteriovenous vasoconstriction, leading to decreased interglomerular hypertension, decreased plasma flow, and decrease in proteinuria. And this is borne out by the trial data. This is meta-analysis of low protein diets, which was shown that the incidence of renal death occurred less in the low protein diet group rather than the usual protein diet group. And in this particular meta-analysis, it was shown that there was no difference between very low protein diet supplemented by keto analogs and low protein diets. So if you consider this, low protein diets have actually been shown to decrease the incidence of chronic kidney, decrease the progression of chronic kidney disease and cause lesser renal death. So this 2020 statement, KDOKI statement on the protein amount states that in patients who are not on dialysis with and without diabetes, a low protein diet of 0.55 to 0.6 gram of dietary protein per kg body weight, or a very low protein diet of 0.28 to 0.43, around 0.3 gram per kg protein diet with additional keto or amino acid supplementation can be obtained. However, patients not on dialysis patients who are not on dialysis and with diabetes, in this patient group, they have suggested that we keep the protein restriction to 0.6 to 0.8 gram per kg. So KDOKI statement basically advocates very low protein or a low protein diet, specifically in patients who are non-diabetic. And when we come to in the case of diabetic patients, the KDOKI statement says that we should not restrict protein all that much, because after all, they are losing some amount of protein in their urine often. However, when we come to maintenance dialysis patients, the protein intake should be increased to 1 to 1.2 gram per kg protein diet. This is the first point. We often continue our low protein restrictions into the patient who goes into dialysis. So the first important point is always increase protein intake in dialysis. That is very critical. Otherwise, the patient will continue to go into malnutrition. However, where is the problem? The problem is this. This is the general population data, and these protein restriction, the idea of protein restriction came from the data over these countries, US, Canada, where you have 90 gram protein diet. If this line is your average daily protein requirement, Indians are hovering here, right? Our total protein intake by the normal population is hovering just above the daily requirement, and most of these are from plant proteins, which are less bioavailable. So we have a much lesser animal protein intake rather than the over the Western data, and we have a lot of plant protein here. So the first question with regards to our population is that since the data came from here, does it apply here? The second problem is that the total malnutrition, prevalence of malnutrition associated with chronic kidney disease in India was found to be 56.7%. So 57% of your patients of CKD are straight away ineligible for a low protein or a very low protein diet, given that they are already suffering from malnutrition. This is higher than all other countries except Mexico and Jordan. So more than half of our patients are straight away ineligible for this very low protein or low protein diet, and even in them, the degree of protein restriction is a question to be dealt with. The second problem myth which we often deal with is that protein restriction, we translate the gram per kg straight away into the grams of fish or chicken. So that is not correct. You see, when we are talking about a gram per kg of say 50 gram per kg, that translates into, if you are taking it solely from a high biological value of protein, it translates into almost 200 grams of fish. So you see the amount of protein in fish ranges from is around 20 to 24%. So 100 grams of fish will actually give you 20 to 24 grams of protein depending on the fish. The chicken also will give you 31% protein. So someone taking a 50 gram protein diet doesn't mean that he is taking 50 grams of fish. If someone is taking 50 grams of fish, he's getting 10 grams of protein out of it. Right. So these are some of the protein content in various foods. You can there are also vegetable sources of protein. If you consider pulses, they have only 7 to 8 grams of protein per 100 gram of pulses. Beans will similarly give you 8.1, 6.9, 5. Wheat will give you relatively more, 12 grams of protein per 100 grams. So actually the total protein content of the diet comes from adding up everything. So you need not translate the entire protein content into the amount of fish or chicken. But still, we should not ask our patients to stop eating protein, because even with a protein restricted diet, you will have to still take at least 100 grams of fish a day to get 20 grams of protein from fish, and then go on to accumulate the rest of the 30 grams of protein from wheat, dal, and whatever else he is taking. But if his protein intake and dal intake and wheat intake and other things go back to zero, he will not get any protein and he will continue to go into malnutrition. Remember that these are patients who are not yet on dialysis. Once on dialysis, the whole thing will shift to even higher requirements of protein. So that is the first protein importance of the actual amount and relative amount of protein which are present in the diet. The next question is keto analogs, and we have already discussed some parts of this in our quiz contest. Basically, keto analogs have been shown to improve decrease requirements of decrease the progression of CKD. However, they are recommended only with very low protein diets, and low protein diets versus very low protein diets did not cause much of a difference in outcome. However, it was shown that very low or low protein diets did not result in reduction of serum albumin or cholesterol. Very low protein diets could increase calcium and lower phosphorus if the estimated GFR was less than 18 ml per minute. However, if you are using keto analogs, remember that the most of the trial data which is there on keto analogs basically restrict protein to 3.3 gram per kg, and they give keto analogs. So how many keto analogs? They give at least 1 capsule per 5 kg of body weight. So you will for a 60 kg person, you will need at least 12 capsules a day. The cost of that will come to around 6,000 to 7,000 rupees a month. So if it has to be used, it has to be used in full doses with a considerable expenditure, and that too in a minority of patients. The next source of myth that I would like to talk about is presence of or intake of fruits and vegetables. So the first thing we tell patients is stop eating protein, and the next thing we tell patients is that stop eating fruits and vegetables. However, once again we go to the Kedoki statements, and these Kedoki statements suggest that CKD 1 to straight away CKD 5, 1 to 5, not on dialysis or post-transplantation, a Mediterranean diet can be prescribed, which will improve lipid profiles. And the second thing they have suggested is that in the patient adults of CKD stages 1 right up to 4, they suggest that prescribing increased fruit and vegetable intake may decrease body weight, blood pressure, and net acid production. The third point, net acid production, is another very interesting point. As we know that with the progression of CKD, there is an accumulation of endogenous acids, which cause more bone mineral losses, as well as cause by itself an increased progression of chronic kidney disease. So this Kedoki guideline suggested that we can try and reduce net acid production through bicarbonate or citric acid supplementation to reduce the rate of kidney function. And in adults with 3 to 5D, it is reasonable to try and maintain the serum bicarbonate levels at 24 to 26 millimole per liter. So one of the ways we can try this is by sodium bicarbonate supplementation. The other way we can try this is by increasing fruits and vegetable intake. So this was a trial which compared favorably treating metabolic acidosis in CKD stage 4, quite an advanced stage, by fruits and vegetables versus sodium bicarbonate. So what is very interesting about this is that the potassium content in fruits and vegetables get excreted from the kidney in these stages because of the fact that the potassium is accompanied by alkaloids and bicarbonate and not by chloride. If it was accompanied by chloride, it would have been retained in the body. However, any potassium which is accompanied by an alkali salt, if the alkali is excreted, we get a better excretion of potassium. And even in a low potassium diet, you see the requirement of potassium is 2000 milliequivalents per day. So a 2000 milliequivalent per day diet is a low potassium diet. So here I have given the amount of potassium in fruits and vegetables. So these are the fruits. If you have if you look at it, 100 grams of potassium is contained. 100 grams of oranges have only 181 milliequivalents of potassium, right? And lychee, 100 grams of lychee will contain 178. Even a mango per 100 grams have 168 milligrams. My point is that if you try and add these up right up to 2000 milliequivalents or even 1000 milliequivalents or 1500 milliequivalents, you realize that we can actually prescribe a lot of fruits and vegetables to our patients, right? So it is an apple will contain only 107 milligrams. You can easily ask the patient to take 4 apples a day. A lot of citric acid will go into the patient. Once that gets into the patient, it will be converted to bicarbonate, and once that does happen, it will make the patient alkalotic. So we are getting overblown with the restriction of fruits and vegetables. This, for example, is the degree or number of potassium, amounts of potassium in vegetables. These these potato 421 milliequivalents, carrots 320 milliequivalents per 100 grams, beets, sweet potatoes, spinach, all these have larger potassium, but the rest of the vegetables do not have potassium all that much. You see eggplants, mushrooms, okra, onions, nothing. 147 milliequivalents in cucumber, 170 milliequivalents in cabbage. My point is that you can add all these up to 2000 milliequivalents and still get a potassium restricted diet. Right. And the point of giving these fruits and vegetables is that we need to increase the alkaloid supplementation, or rather increase the alkali delivery to the patient, so that we can get a increased bicarbonate delivery and decrease the net acid production, and thereby decrease the progression of CKD. And this has been recommended in the KDOQI guidelines. And these are my main two myths. That we can talk about many other things. We can talk about exact sources of salt. However, these are the main two myths regarding CKD and diet that I wish to highlight. In conclusion, I would like to leave you with this diet chart with a North Indian menu and a South Indian menu for a 0.6 gram per kg, which means a 36 gram protein diet. And this is entirely vegetable, right? So you can see that these patients can have lentil 15 grams, vegetable 200 grams, cereal and starch flour, at least 200 grams of fruit every day, and as well as yogurt, lentils, chana dals, cow milk, everything. And this will be a perfectly fine diet for them. Right. So thank you, and that was thank you for your patient hearing, and that were the 2 points I would have like to make regarding myths of kidney disease and its realities. Thank you very much.
Excellent talk. I think you have brought out all the main points about the fallacies of understanding and the fallacies of the advice that we sometimes give and what patients make of it. We may be advising something, thinking a certain way, but patients actually they take it in a different manner. So let me just add 1 or 2 points. I think the greatest myth is that there is some diet which is good for the kidney. The general belief is that. So when the patient goes to a dietitian or comes to us, they want to hear this, that there are certain addition of certain things are going to be good for them. Unfortunately, there is nothing such. So that's the first shock when we tell them there is nothing such. On the other hand, we start restricting foods, items. Now, what I have noticed there, and what Dipankar had explained very clearly, that in the process of restricting, we often over-restrict things. This is true because our average may not be that much, because all this thing came from the Western diet where the animal protein component is really much higher than the Indian diet. So many times when we restrict, you really go down. Sometimes the opposite happens, that we say, okay, you can't have this. On the other hand, you take this, and you see a dietitian's chart, and there are many patients who also tell that I never eat that much. Like the restricted protein diet, what the dietitian has given, sometimes they say that we don't eat that much also. And sometimes people get very hung on that diet. If they say 40 gram protein, or they think it's a 40 gram piece of fish, and people go to the market, they cut out a fish. This is just going to the extreme. All these these things really don't make much sense. So if you're reasonably okay in your diet, probably a little bit here and there will not matter so much. You don't need to be hung on the 30, 35, 40. I think this is mainly for the students. You have to, the diet changes. Someone in Kerala, someone in Bengal, someone in Uttarakhand, the diet is different. You have to allow for that little variation. Second, about potassium, what I would say, potassium is important. You have given all the charts. Now it's important to understand that the potassium handling capacity of the kidney is also dynamic. What the kidney can handle at CKD3, the kidney cannot handle at CKD5 without dialysis, and on dialysis, different thing. So you may be beginning with what you do in a dialysis patient. You may not do that with somebody with CKD3 with a creatinine of 4 or 3.5. You don't need to restrict so much of food, so many things, because it messes up his kind of life. Now, also the other element here is the addition of drugs. Majority will be on an ASARV kind of drug. And now you have the mineral corticoid, though the MR is now coming in. So you're actually making it more complex, that how much is the drug contribution to the hyperkalemia, how much is the diet contribution, and remember this is a dynamic thing, and it's down the slope, like what now his creatinine is 1.7 and he's not on any drug, tomorrow his creatinine is 2.5 and he's on something. So it's quite different. So your fluid advice, the potassium advice also should keep on changing. The third is the amount about the calorie, I think, which you have said already. And the thing probably you did not say, but is about the water. But again, it's not coming in nutrition per se. But again, this over tendency of restricting water anytime you have a creatinine of 1.4, and people also get completely messed up in that. You really don't need to say anything about water, just go by thirst. Unless there is a tendency of swelling, if there is a tendency of getting swollen, then you have to restrict water. Otherwise, don't. If somebody with a creatinine of 10, some interstitial diseases, the CKDU, you find that they are completely, they are passing 3 liters of urine. And if you restrict, you can cause a problem there, actually. So water intake guided by thirst, unless there is swelling, in which case you restrict. And if you're giving aerobic, then accordingly. And again, a dynamic thing, CKD3 and CKD5 in the same patient will have a different water intake advice. You must understand that. Dr. Ghosh, you want to add something?
So now it is open for the question and answer or any comments.
Yes. The Calcutta population is 65% is veg and 35% is non-veg. It's a recent report going on. So what's your idea about kidney disease and veg non-veg diet? Does it differ? And second is whether milk is a veg protein or a non-veg protein.
So milk is,
what is the role of parboiling of the food to decrease some ionic components? These are 3 questions.
sir, milk is a non-veg protein. It is obtained from cow, so it's considered to be non-veg. It's a process of leaching, not parboiling. The leaching is done by slicing in the vegetable into 1/8 pieces and then first boiling it and then soaking it in hot water for about 2 hours and then going ahead and cooking it. So that process decreases potassium. It also decreases vitamins and other things that are there in the diet. The point is that, sir, if the patient has a serum, you go and measure the serum potassium. If the potassium after giving telmisartan and all other drugs is maintained between 3.5 and 4.5, just we can safely continue the diet. If we see that our potassium is increasing, then we have to ask them to go ahead and do leaching. We have to go ahead and restrict potassium, start restricting potassium, or we can actually give a loop diuretic or a thiazide to get more potassium out of the body. And so what was your third?
About the veg and non-veg diet.
Veg and non-veg diet. The interesting thing is that the person who is actually taking non-veg in Kolkata takes 1 piece of fish, say it's 75 grams or something.
Not every day.
And that too not every day. I mean, even the vegetarian, so-called non-vegetarian, is practically taking a vegetarian diet. The amount of fish and chicken that we usually take is so little that we need not consider that diet in our. The fact is that most of our patients have a we are already on low protein diets. And for that reason, our creatinine and our uremic symptoms occur much later than we would have otherwise seen in a patient with on a Western diet. So what we get is when our patients become uremic, all possible kidney reserves have been already lost. You will not, our patients who have finally reached, in spite of losing muscle mass, we are having anorexia, where protein wasting has occurred already. And finally, when our patients get a creatinine of 4.5 or 5, I believe that it reflects a far lower GFR than it would have otherwise reflected if the patient was having a healthy figure. So if a patient who is well built has a creatinine of 5 or 6, that is there. But if a emaciated patient has a creatinine of 3.5, even that creatinine is very significant because he has very low muscle mass, and that is the maximum creatinine that muscle mass is going to get. So
which the animal proteins can provide. So if your CKD patient is completely on plant protein, there are few advantages, as you have already mentioned, and things are coming up that plant proteins may be good for. Then you have to supplement them with essential amino acids from keto analog source, and which are not very affordable for an LMIC country like India. At least for vegetarians, we need to convert them to vegetarians to balance the essential amino acids at a cheaper cost.
Yeah, or they will require some protein supplements.
Or they will require some amino acid supplements. And albumin, which is very important, that we find that prognostication of every acute sickness is coupled with albumin. Even how the patient will do in dialysis is coupled with albumin. So all our diabetic nephropathy advanced patients are coming with a 2.5 albumin, and we are fighting with infusing 5,000 rupees cost albumin every day.
Yes, yes, sir. All these stories will start only if the patient is actually having malnutrition. He is not having malnutrition. If the patient is having malnutrition, you have to supplement protein, you have to give more protein, everything. And what sir said about water is very important, because I could not we did not include every aspect in this talk because it was a short talk. But the one more interesting thing about this is that a CKD patient loses the ability to concentrate his urine. So if he is actually taking less water, he is more prone to dehydration rather than a patient who is not CKD. So if we ask them to restrict water too much, he will go into prerenal decay, because he's ADP, interstitial disease patients, all these will have a non-regulated urine output. So
It's not a blanket
everything
water
depends on
restriction.
the urine output. It differs from person to person.
In fact, if the patient
whole dictum last 24 hours urine volume plus 400 to 500 ml extra water intake. That is the standard method. Because some CKD patient passes only 500 ml urine, other person 3 liters of urine.
Exactly.
So it depends on the urine output and edema. Urine status is very important. Whether he has hypertension, edema, cause neck pain, or so that is to be assessed.
Yes, absolutely, sir.
Number 2 is
any question from the postgraduates?
should we be bothered about the acid content of the fruits in late-stage renal disease?
Acid content of? Acid content of no. If you are giving fruits, whatever acid is there in the fruit will be converted to bicarbonate acid. Usually it's citric acid. It gets converted to bicarbonate. You get acids from proteins, animal protein. That is one of the problems with animal protein, that they have a given acid load, especially with sulfur containing amino acids. These are coming only from animal protein. So acid loads it's rather the other way around. When fruits will give you alkali, that's why we are prescribing fruits.
Proteins are supposed to be very big. The acid load is not big.
Yeah.
But the citrus fruits are rich in potassium. They are all.
That's what I said, sir. It is not that rich always.
So, yes, Dr. Ghosh. You take the mic.
Well, the progression of the renal disorder, I mean the particularly age related, after some part of our life you have relapsed, so decrease in the GFR is inevitable. Yes. So can the non-veg protein, I mean the plant protein and animal protein has got any difference in the to decrease the progression of the renal disease or loss of GFR? Am I convinced you about the question? Is it the question is
So
okay?
you're asking if we take
Yes.
okay. Yeah, right. Then I will wait for the next one.
Dipankar, please explain. You have shown that in a CKD patient, daily requirement of potassium is 2000 milligram. Is it correct?
Yes. But that is a low potassium diet. That is a low potassium diet.
So I'll just finish up with just one more statement. I think it's a rather simple way to handle this dietary issue. So I think I'll just tell you what I do. For a vegetarian, for an average vegetarian, you are not exceeding the protein requirement limit. So you don't need to bother so much unless the patient is drinking more than 1 liter of milk in a day, which is also rare. So by and large, the vegetarians, you are not exceeding that. So no need to really tackle much other than the potassium. You may not really worry about the protein so much. If it's a non-vegetarian, it's a big one like us. You ask, before telling about the protein restriction, just ask them how much protein it takes. So now I have been doing this for last so many years. Before telling anything about that, I said, how many pieces of fish? Kotugro mach khao week. Shoptahe kotugro mach khao. So generally people have one piece of fish in a day, generally, even less, 4 or 5 pieces in a week. Mangsho kami loke khai, chicken sometimes, eggs maybe two. This is the average intake. This is also not exceeding too much. This is well within limit. If you think somebody is exceeding, just cut it back. Otherwise, don't tamper with the diet so much. And that would be my final advice, and particularly for the physicians. No need to restrict water. I'll just say this again and again and again. Anybody I see that creatinine 1.3 and diabetic become 1.3 is water cut down to 1 liter and everything they cut down and they come absolutely problematic way. Dr. Chatterjee, you want to add something?
Nothing more to add. Really speaking, what I believe is let physiology do what that has to be. We don't need to go for minute corrections. You do a gross correction will do gross something. Minute correction will be done by physiology.
I mean, although my saying this maybe sound a little extreme, but I'll just tell you, is also there's a need to understand this. When we were students in hepatitis, probably you don't do it now. In hepatitis, people used to stop fat. That practice is still there to some extent, but in Harrison wrote even 30, 40 years back that the physician should not interfere with the diet. It was clearly written because it is allowed, generally what you are able to take it. In renal also, it is almost the same. Unless somebody say, if you are uremic, you will not be able to eat protein. So many people say, I can't stand the fish. So then creatinine already 5, 6 level, he cannot stand it. There is a physiology. So you need to restrict only few things and don't be so much hung on the numbers. So that also creates an undue area of complexity. That's the main advice.
Thank you very much.
Thank you, Dipankar, and also Arpita for arranging this type of seminar CME with API. Thank you again from API.
Yes, I quite enjoyed the quiz. Call me more often.
Boys have spent a lot of effort. Chocolates for your daughter. They thought that we will get 4 times 2 weeks. And they must be really unhappy with the chocolates.
Thank you, sir, for your explicit lecture. Now, to move on to our last session, from the nutrition in CKD, we move to approaches how to prevent the progression of CKD. And for this session, I would like to call upon the stage our chairpersons, Dr. Nandini Chatterjee, Madam, Professor of Medicine, IPGMER, SSKM Hospital, Kolkata, Dr. Partha Sarkar, sir, Professor of Medicine, Calcutta National Medical College, and Dr. Jyotirmoy Pal, sir, Professor, Department of Medicine from Archika Medical College. Partha Sarkar, sir.
Good afternoon, everybody. So we are moving on to the last topic of the day, how to prevent CKD progression. The importance of prevention of progression of CKD cannot be understated because of the economic burden, the poor quality of life, and morbidity that CKD means. And for this, we have Professor Orpita Raichaudhuri, who needs no introduction, who will be enlightening us on this topic. She's the professor of Department of Nephrology, IPGMER, Kolkata, Joint Director, Regional Organ and Tissue Transplantation Organization, and editorial board member of the Indian Journal of Nephrology. Madam, the stage is yours.
Thank you, Nandini, for your kind introduction. At the end of the day, we move on fast, but the thing is really worrying. If I just start with giving you a picture of 853 million of CKD population on Earth, which is even more than a continent's population. Europe has 750 million population. CKD population is more than that. 1 in 10 is suffering from CKD amongst us. So 2.6 million people who are already on ESRD and taking dialysis or transplant. We will be doubling soon by 2030. By 2040, it will grow to be the 5th important cause of death. And 13 million people are suffering from AKI, and not all AKIs are benign and to end within 4 weeks. They may move on to CKD in a significant number, and the costs Nandini had already mentioned on the dialysis and transplant that our poor country and many other high-income countries are spending. So 463 million of diabetes, and if 40 to 50% turn CKD, just imagine the burden of CKD we are going to face in current years. And where we are regarding preventing progression, we are stuck in the era, we were stuck in the era of 2001, and up till maximal, you can go up to the roadmap trial with olmesartan, which helped us in type 2 diabetic normoalbuminuric patients even, which was done in 2011. And after that, it's almost barren till not a new molecule launched in. So to sensitize that what we can do in this respect, again, we can go to how to improve outcome. This is very important because we want to cut down expenditure, we want to improve quality of life, and we want to ease out our job too. So we need to recognize CKD early. I will show that early appreciation cuts down the sufferings. We need to prevent the progression and improve CKD outcome. How can we do that? All of us know that control of blood pressure is a very important measure. The new input is what should be the target blood pressure. The new input is all the kidney patients, mostly the diabetic nephropathy patients, are requiring more than 3 antihypertensives. What to do if they need after A, C, and D? So we add ART, go to the guideline, we add ART first, then CCB, then diuretic. What if the blood pressure is not controlled till then? Improving cardiorenal outcome. So what are the new molecules? SGLT2I, finerenone, atrasentan, and sparsentan, few molecules we will be talking about. And another important thing is stop AKI, because AKI is not a good thing, particularly AKI on CKD. When a diabetic nephropathy patient is housed in nephrology department with an acute pyelonephritis hitting a creatinine of 6.6 or a drug-related creatinine rise going to almost dialysis need, they always do not come down to the level of non-dialysis requirement. So how can we detect CKD early? We were diagnosing CKD by creatinine level, but we need to know that creatinine at a 6-year, creatinine of 1 for a 6-year-old boy, creatinine of a pregnant mother, 1 creatinine of a pregnant mother, and 1 creatinine of a 8-year-old male are not the same. So we need to translate them to eGFR. So that CKD definition is
no more dependent on creatinine. It is rather dependent on eGFR, that is estimated GFR, and albumin creatinine ratio. So you can see, if we see the eGFR is lower, you need to have a small app in your mobile phone, smartphone, to get an idea about GFR, which can give you that idea within a minute. And you need to count the so you can see not only the diagnosis, the prognosis also worsens when proteinuria goes bad. Even if it's a good GFR, the patient goes into this brown zone, which is moderately unsafe. And when both are bad, they are at risk zone. They are responsible for increase in all-cause mortality, CV mortality, ESRD, AKI, and progressive CV.
The mic, closer to the mic.
Hello. So, incidence of ESRD increases as your dipstick proteinuria goes high, which is lower when your dipstick proteinuria is low. Early intervention will help you to delay the progression, whereas late intervention will make it faster. eGFR and urine ACR, if you add on the top of the traditional model, it will help you. You just see that it will help you when to prognosticate whether the cardiovascular mortality will be high, even if there is diabetes or no diabetes. So not that diabetes is only proteinuric disease, the hypertension or no hypertension. This proteinuria and eGFR can help you in taking action faster, closer, so that your patient gets a benefit. And cardiovascular outcomes are very important in CKD patients. If you look at this, you will find that before going to dialysis, many patients suffer from cardiovascular death. Few patients go to ESRD. And if you don't take in account the cardiovascular risk issues in a CKD patient, you cannot give a good outcome at the end. So consider CKD as a cardio-renal metabolic overlap and improve the CareMe model so that you reach the Steno 2 outcome with multifactorial intervention. You can see 21 years of follow-up, not a single dropout, and all-cause mortality is significantly reduced. This type of all-cause mortality reduction was only available with UKPDS follow-up and DCCT-AD group. Even the blood pressure control alone didn't give this type of good outcome. So what will be the BP control, whether we will go for intensive or usual? We know the sprint trial was on board. Long before the sprint trial also, Bakris at 20,000 had shown us that lower the blood pressure, better is the GFR fall. GFR falls only 2 mil if you can reduce blood pressure to this level, provided your patient can tolerate this blood pressure. And we went up to this soft blood pressure control of 130/85 or 140/90 by guidelines, because we looked at many patients, diabetics, non-diabetics, patients with autonomic neuropathy, aged patients who may suffer from autonomic neuropathy and various other frailty, so that the falls we wanted to avoid syncops. What sprint showed us, sprint was terminated even before the time was there, time for the trial was there, because it showed an immense improvement in the cardiovascular outcome. So cardiovascular, and remember, sprint did not include the diabetic patient. So the autonomic neuropathy aspect, the fall frailty aspect to some extent minimized. The previous BP intervention strong trials included diabetes. So sprint, CKD or no CKD, improved the cardiovascular outcome. What they could not do, the CV composite, this broken line is showing the intensive control, and this is the bold line is the CV composite outcome of the standard group. So events are more in this group. It offered CV composite outcome benefit, which is decreasing the heart failure, decreasing MACE outcome, and improved all-cause mortality. As you can see, events are more in this bold line rather than this broken line, which represents the good broken line intensive control. So what sprint couldn't show us immediately, that is the improvement in main kidney outcome. So the CKD subset has been taken out and it has shown a GFR drop. But when they looked into the tubular injury markers and followed up the patient, what they saw, they followed up the patient, they saw that intensive control lowers proteinuria, the GFR is still low, but intensive saw slight higher rate of eGFR decline. But what happened? Initially, 30% eGFR reduction from baseline was significantly more in intensive treatment group. You can see a significant p-value. But when you look at after 6 months, you find this reduction is stabilized. So the GFR becomes stabilized at a little higher level, but the cardiovascular outcome improves. So whenever your non-diabetic CKD patients can tolerate, particularly proteinuric patients can tolerate a lower BP, you can, recommendation comes out to improve the CV outcome, to improve the overall outcome in terms of all-cause mortality, you should go for intensive blood pressure reduction. But for diabetes, you need to consider at the clinical situation all around. So your patient is no guideline, no trial, a real world patient, and you need to look at with care that what the patient is actually going to have. So we next come to the resistant hypertension. Which one will be better, spironolactone or clonidine? There is a tendency that we go for the sympatholytics more when we feel difficult that I cannot control with the typical recommendation. Spironolactone versus clonidine trial has shown that their BP control is almost similar, the primary endpoint. The secondary endpoint analysis showed similar office BP. Ambulatory BP monitoring is 44% versus 46%, which is also comparable and gives spironolactone a non-inferior status. What more it showed? That it showed greater decrease for 24-hour systolic and diastolic BP and diastolic daytime ambulatory BP than clonidine. Part protocol analysis showed that similar results regarding the primary endpoint. So we may try spironolactone instead of clonidine as the fourth alternative whenever possible. We need to look at the hyperkalemia for advanced CKD patients very carefully. Targeting proteinuria and diabetic CKD, you can see that the disease progression is associated with endothelin receptor activation, which gives rise to mitogenesis, vasoconstriction, cellular and mesangial proliferation, ultimately leading to fibrosis. The beneficial ETB receptor will get upper hand if you can block this. So endothelin blockers are tried, and we can see that endogenous endothelin increase happens with diabetes, obesity, insulin resistance, all the day-to-day things that we see in our practice, the aging process even. So increased endothelin is associated with multiple bad effects in the tubule and interstitium to push to CKD. So CKD progression probably in proteinuric patients can be addressed with endothelin antagonists and ARBs. I'm not going to the detail of the trial, but just inspiring you to move on to that aspect so that you pick up. So next is the Finrenone. You have learned about, must have heard about the Fidello and Figaro. I am talking about the renal disease outcome with Finrenone. The molecule is different from aldactone. Why? Spironolactone or eplerenone. Why? The MR directly affects the large target gene expression, primarily fluid, electrolyte, and hemodynamic homeostasis, but as less appreciated in tissue remodeling, but it does tissue remodeling. And the Finrenone receptor distribution is favorably, it has a cardiorenal distribution balance in a way that it is supposed to cause less hyperkalemia. So we wanted to take the advantage. You can see the red line placebo, hazard events are more, composite outcomes, and the separate, each one separate outcomes. The red line hazard events are more, and the blue line hazard events are less. What you should, and you can see here also in the forest plot that the kidney disease progression is relatively less on the spironolactone group. But what you need to remember again, the hyperkalemia is not completely absent. Actually, these molecules benefit so much that in waste, where pocket is not that much a problem, the patients are insurance covered or come from a large GDP country, they are thinking of combining two, anti-hyperkalemic agent and pro-hyperkalemic but anti-fibrotic agent to prevent progression to CKD. So every model cannot be replicated in us, but where possible, whenever possible, go for it, because in next few years for PGTs, the medicine fate will depend upon you. So somebody was asking in the, Dr. Ghosh, where is he? Dr. Ghosh was asking about progression of acidosis and how acidosis can progress is important in CKD progression. I was telling that I have one slide that when there is increased acid retention with fall of GFR, there is decreased interstitial and intracellular pH. There is increased ammoniogenesis. ET1 and RAS is accelerated. For some point part of time, it goes for an adaptive response. But when the adaptive response cannot manage it, it goes for the maladaptive response. Then the complements are activated and CKD becomes a inflammatory milieu, aseptic inflammatory milieu. Activation of complements, pro-inflammatory and pro-fibrotic mediators will push to tubular interstitial and injury and fibrosis, loss of functioning nephrons, and CKD progression. So there is a normal acid-base balance, eubicarbonate metabolic acidosis, then non-acidemic hypobicarbonatemia. So what we are trying to say that bicarbonate level is being managed till long. When we find that bicarbonate is low, it is too late to intervene. We need to look at the pH and start our bicarbonate replacement. So it has shown, this trial has shown, it came from a Japanese group, Tajimoto S and et al. It showed that when the pH is low, you need to start bicarb really, because there the subset with low pH and low bicarb, they progress to dialysis requirement faster than those that pH is preserved. Significant residual risk remains even after use of RAS inhibitors. So we badly needed some more drugs. All these drugs are showing the residual risk is significant even after use of this magic molecule which came as ACE inhibitor or ARB in the first of this century. And there is a huge unmet need in the area of heart failure and CKD, because exerting there is an acute cardiorenal component where we are all confused. Increased diuresis may increase the creatinine level, people get frightened, heart failure drugs may get accumulated with low eGFR, all the ACE inhibitor and MRAs can cause hyperkalemia. So we needed something there. And SGLT2I, first published trial in 2015, came as a rescue in a huge way. It decreased the sodium glucose absorption, it decreased the metabolic demand, increased sodium delivery to the distal tubule, afferent arterial and vasoconstriction is increased, so hyperfiltration is reduced. The hyperfiltration injury is the key point when the systemic hypertension is directly transmitted to the renal compartment, renal hypoxemia improves, renal blood flow is decreased, the hyperfiltration is taken care of. There is alternative metabolism stimulated through beta hydroxybutyrate stimulation, pathway stimulation, and that increases EPO. Hemoglobin grows better, and erythropoiesis is stimulated, iron utilization better. So we get a comfortable situation in CKD patients as well as heart, as shown in the pathological model and clinical trial. And so many individual members of the group, canagliflozin, dapagliflozin, empagliflozin, all replicated the cardiorenal outcome benefit that we are confident about this molecule. There's probably this molecule is going to give us all this benefit, and we are really we have got a really another good molecule after SR. So you can see that all the GFR ranges the trials have done, GFR ranges of 60 to 70, these are the trials which gave cardiorenal benefit, GFR range of 80, 90, these are the trials which were the CVOT safety trials and secondary outcome and renal outcome, but gave both cardiac and renal benefit. And truly bad renal patients also have been benefited. And DAPA-CKD did a wonder because it did not only improve the diabetic people, but also improve benefit was translated to non-diabetic as well. So I'm not going in the detail of SGLT2I trials. You can this is a most discussed molecule in several forums, and ultimately dapagliflozin had shown that it showed benefit in both areas, and other studies like EMPA kidney are also coming to show that probably the first reports that I have seen in the conference presentations are again telling us that empagliflozin will be able to replicate it. So primary composite outcomes are all benefited, whether the person had low proteinuria or high proteinuria, the higher GFR or lower GFR. So we are mostly confident as to include SGLT2I coming from the KDIGO guideline after the non-pharmacological measures. We are finding the first line drug therapy, it included in the 2020 guideline, asked us to start even when the GFR is up till 20, and we may continue until dialysis or transplant along with metformin. So with that, I was talking of that awareness is required for these drugs which can give another blow to your patient. NSAIDs, gentamicin, casually used in an elderly dehydrated person who came for AGE or UTI, contrast for coronary cath, congestive heart failure with diuresis leading to AKI and low BP. With that, I'm very grateful to the researchers in the renal field who have shown that it's not the black and white race which discriminate the propensity to develop CKD. It's not the race. We have removed the race from the EGFR equation, and socioeconomic deprivation and CKD. You can see everything is telling about my country. The residential segregation, the poor educational system, overcrowding, poor housing, increased environmental toxin and infectious disease exposure, chronic inflammation, low literacy, low access to the healthcare service, all will give rise to these complications like low birth weight, obesity, diabetes, hypertension, CV disease, endothelial dysfunction, all of which pushes to CKD or CKD progression. So it's the low per capita income and the poor educational system, poor health literacy, which we need to address simultaneously. And I'm sure that some of the new generation will work a lot in this field and save my country from expenditure on dialysis and transplant, and we will be seeing a better future ahead.
Sincere thanks to Professor Raichodhuri for a brilliant educative talk on a subject that is very
needed at this hour. Considering the irreversibility of the disease, chronic kidney disease, and the huge burden, it is the prevention that is the thing that we can do. We cannot do transplant in all the cases, and dialysis is never ending. So something new to come up, and that thing is under research. But now what we can do is the prevention is the thing. For that, we have already discussed early detection from the very initial symptomatology, where we can discuss the easy fatigability and other things, lack of sleep. We suspect those which condition lead to CKD. Then starting with the diet, already discussed, a healthy body weight, that has to be maintained. Regular exercise. Yeah. The exercise, regular exercise, that is also a necessity. We did not, this is not the forum to talk about the non-pharmacological one. Maybe some non-pharmacological things need to be discussed. And the comorbidities to be tackled in a right way: diabetes, hypertension, hyperlipidemia, heart disease, because almost 8% CKD patient die of cardiovascular disease. So that has to be taken care of. And then the important side, that was the medication that is indicated and not indicated, that has to be taken care of. Socio-economic status, we cannot interrupt much in our setup because that is very difficult area. Then the modern medication that you said, SGLT2, Finri, known as just FD approval has got recently, Altracetron, you have said. But I want to know one thing: ACEI and ARB, CCB next. ACEI and ARB, lot of studies in heart failure shown ACEI is preferred to ARB. But in case of kidney disease, which one you will prefer? Given the choice, ACEI or ARB?
No difference in head-to-head. No difference. We get benefit from it.
Thank you. Then I can have some comments or questions from the PGTs or the nephrology faculty, if there is any comment or questions.
Actually, yes, cardiac video. The AC inhibitor increases the level of bradykinin, which is a potent vasodilator, and that is why it is beneficial for the heart. Decreases afterload and increases coronary circulation, etc. But in case of kidney, both are equally good, ARB and AC inhibitor.
And the PGT, yes. In the mic.
So one question.
PGTs will get privilege. Question.
Ma'am, many a time we in our OPD setup and in our ward also we came across diabetic kidney disease patient come with serum potassium around 5.3. It's a much higher level, and we already patient is on AC or ARB inhibitor, calcium channel blocker, and diuretics, and patient BP, the BP is not controlled, and for that time being, we are starting alendronate. So what would be the interval to check the serum potassium and creatinine value? Because there is every possibility of hyperkalemia. And many times it is not possible for the patients also to come in the OPD, or in they are lost to follow up many times. So what would
likely to cause a rise in hyperkalemia with the same dose. If you give a 28-year-old individual and a 78-year-old man, the older man may hit hyperkalemia. So, and there is another important issue in the elderly who are suffering from hypertension and diabetes. The hypertensive patients can have a significant amount of atherosclerotic disease, which may remain silent till not you add up the ACE inhibitor and ARB. With ARB, you make the patients more vulnerable to get hyperkalemia. So what we do in regular practice as nephrologists, whenever we prescribe ACE-ARB, even with a lower, with a better EGFR, we ask the patients at least to check potassium and creatinine after 1 week, so that they can and teach them that if it goes above 5, come to us, take the information. We will need to decrease the dose, and usually it's better to start from a lower dose and then escalate to a higher dose. Sometimes for proteinuric diabetic patients, we keep on increasing. And you can make a careful combination of diuretics and ACE inhibitor. Diuretics, when given, can cause some degree of potassium loss, as well as upgrades the renin-angiotensin system, so that you can get the ACR-related effect better. So that's also a way you can address these patients. But doing this creatinine and potassium is very important after a week. Sometimes they hit even after 2 weeks, 3 weeks. And where I'm more suspicious, I ask them to get even after 15 to 21 days for a creatinine potassium value.
Ma'am, we generally came across that some patients come to us with creatinine level around 2.3. They come to us.
I'm repeatedly telling you, when you are mentioning creatinine, it's a good, easy marker, reproducible, all right. But remember, you are internally, you are calculating EGFR. Be in that habit that you are calculating EGFR, and you are not looking at an AKI patient, but a CKD patient. AKI patients can hit so for a transient period of time, and CKD patient may have that as a permanent. So translating it to EGFR, then take your action. If the 2.3 happens in a female of around 60 kg or 50 kg weight, or a lean and thin patient, or female patient particularly, a creatinine of 2.3 is GFR3B, G3B, sorry, GFR3B, not G3B. That is the level of EGFR is close to 30. So in that EGFR, you need to be more restrictive about potassium.
No, I think it's already we are very late. So we have to conclude this section about
Mic to the
come to an end at some point of time, and we'll have ma'am all over the time. So talk to her for your further education.
So thank you, the organizers, API and Indian Society of Nephrology for arranging such a good crosstalk between the API and Nephrology Society. Thanks to all the organizers. And conclude the session over here. I think the announcer will describe about the valedictory dates.
Thank you, madam, for this illuminating and wonderful lecture. Now, for this valedictory session, I would like. Now for the valedictory session, I would like to call upon the stage my respected faculties, teachers who motivate us, guide us to attain academic excellence. For this, I would request to come upon stage Dr. Devabroto Shain sir, our head of the department, Dr. Arpita Roy Chaudhary madam, Dr. Udas Chandra Ghosh sir, Dr. Prateek Das sir, Dr. Nandini madam, Dr. Jyotirmoy Pal sir, to come upon stage, and Dr. Partho Sarkar sir to come upon the stage and distribute the prizes among the winning teams of the competition. Apart from the winning team, all the participants will be getting the certificate for participation and some mementos. Now for the first team, Team A of Shubhajit Das, Shobhik Mandal, Mohabbat Ali Ansari, please come upon the stage and receive your prizes.
আরে লাইটটাকে জ্বালাচ্ছে বলে
I
জ্বালালে
would request Dr. Devabrata Sen sir to give the first team their certificates.
পড়াশোনা করে আমার কাছে এসো সবাই মিলে
তো মাইকে
For the second team of Shubhankar Roy, Saurabh Metia, Kaushik Karmakar, please come upon the stage and receive your prizes. For the third prize, I would like to call upon stage Now for the third prize, the team of Dr. Rahul Devnath, Dr. Arundhati Das, Dr. Vipresh Chakrabarti, kindly come upon the stage and receive your certificates and prizes. Thank you, ma'am. Now I will call upon all the participants by calling their name, and they will be receiving their certificates of participation. Dr. Saurabh Sen, Dr. Devrup Sengupta, Dr. Anayjati Kundu, Dr. Shubhajit Das, Dr. Amrita, Dr. Devrup Sengupta, Anayjati Kundu, Dr. Shubhajit Das, Dr. Pallab Sinha, Shubhajit Das, Amrita Das, Dr. Abhinav Das, Dr. Kaushik Mukherjee, Dr. Shubhra Shankar Sen, Dr. Shautrik Ghosh, Dr. Ritam Mukherjee, Dr. Kirtiman Mondal, Dr. Tathagata Ghosh, Dr. Amit Kumar Sarkar, Dr. Shobhik Sarkar, Dr. Aniket Chatterjee, Dr. Shobhik Sarkar, Shobhik Sarkar, Kirtiman Mondal, Devupratim Ganguly, Jita Mitra Mondal, Shobhik Sarkar, anyone left?
API না বললে হয় original must take first for covering this
At the end, vote of thanks. Really, on behalf of Association of Physicians of India, West Bengal branch, I convey my sincere thanks to Indian Nephrology Society, mainly the SSKM chapter, SSKM hospital chapter, Department of Nephrology, Dr. Orpita Chaudhary and Rajuri and her team for arranging this type of program with API, and we also expect in our future program in this way. And I also give sincere thanks to all the faculty members of this institute, and also those who are participating as a faculty, as a chairperson, and as speaker in this program, and also all the delegates and the participants, particularly postgraduates, and also other delegates. And special thanks to the pharmacological companies, mainly the Boehringer and also the State Farm, because they are continuous help for this program. Thank you all. Now we are concluding our session here.
And to extend my thanks particularly to the postgraduate students and my nephrology department students, because without them this type of CME activity remains practically impossible.
एक तो বাইরে খবর জি এই পূর্ণিমা আপনার মনে হচ্ছে নিজের এখন সবাই বড় বড় চকলেটের দোকান এটা কে কি চকলেট খেতে
ওই
চকলেট খেতে
ও
এই পূর্ণিমা একটা রেখে নিয়েছি এই হাতে এটা আমি একটু মেয়েদের বেশি ভালোবেসে পানি অমনি হঠাৎ করে গিয়ে ফুল দেয় একটু তো ইয়ে অমনি তো মহিলাদের ফুল দিতে বলা হয়